Assalamu alaikum. Good morning, everyone. It is a pleasure to welcome you all to the 10 Hot Topic in Pediatric Neurology Symposium. We are delighted to bring together colleagues and mentors to discuss practical, high-yield updates across key areas in our field. Before we begin, I would like to wish you all a blessed Eid, as we just celebrated it. Eid Mubarak to you and your family. Wishing you continuous health. It is a truly honor for me to host this symposium and to share the stage with esteemed mentors and professors. I hope that today's sessions be engaging and valuable. Thank you again for being here. And without further ado, I would like to present the opening remark presented by our symposium chairman, Dr. Ashraf Amir. Dr. Ashraf is a distinguished consultant in family medicine and the chief medical officer of the International Medical Center here in Jeddah. He also serves as the honorary assistant professor of medicine at Al-Qura University in Mecca. He contributes to the academic development of future physicians with strong commitment to family and community medicine. Dr. Amir is the vice president of the Saudi Society of Family and Community Medicine and a member at large of the World Organization of Family Doctors for the Eastern Mediterranean region. Over the course of more than 3 decades, he played a pivotal role in Saudi Arabia and the healthcare system, combining his expertise as a practitioner, leader, and the advisor to support the Saudi ongoing healthcare transformation. Dr. Ashraf, please. How can you open the slide? Can you open the slide?
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Distinguished guests, esteemed speaker, respected colleagues, and dear participant, Assalamu alaikum wa rahmatullahi wa barakatuh. On behalf of the Saudi Society for Family and Community Medicine, it's my great honor and pleasure to welcome you here in this important scientific event, 10 Hot Topics in Pediatric Neurology for General Practitioners. And we are proud to support, as a Saudi Society for Family and Community Medicine, we are happy to support this gathering, which brings together leading experts and dedicated healthcare professionals with a shared commitment to improve child health. As you know, pediatric neurology is a rapidly evolving field, and its integration to primary care is essential. As general practitioners, we are the gatekeeper of the healthcare system, and we are the first contact with patients. And for that, we have to demonstrate our commitment and accountability in screening, diagnosis, and proper referral, and above this, the proper management of our patient to prevent disease. So prevention is very important. So today, our program has been meticulously designed to address some of the most pressing and relevant topics in pediatric neurology, from epilepsy and neuromuscular disorder to neurodevelopmental and behavioral conditions, rare disease, and the growing role of artificial intelligence in clinical practice. So this reflects our shared mission to equip frontliners, physicians, with practical evidence-based knowledge that make them competent enough to manage patients in neurological disorders. We are honored to have with us an outstanding group of speakers and experts who will share their knowledge and expertise and their insight. And I encourage all of you to actively participate and engage in discussion and take the full advantage of and the opportunity to learn, connect, and collaborate. I would like also to thank our partners, the Saudi Pediatric Neurology Society, the Saudi Epilepsy Society, and the Saudi Arabian Neuromuscular Electrodiagnostic Medicine. Special thanks goes to Dr. Anas Al-Yazidi, the champion of this wonderful event, who initiated the idea many months ago, and he worked up every single piece of this event to make it happen. Special thanks goes to Fexus Company for the wonderful organizations of this event. And I would like to thank you all for being here today and wish you a productive and enriching and inspiring conference. And with this, we will start, inshallah, ala barakatillahi nabda.
Thank you so much, Dr. Ashraf. Truly a leader in empowering young physicians. It is a big pleasure to welcome the second opening remark for today, delivered by the SPNS President, Prof. Fahad Bashiri. Prof. Fahad Bashiri is a consultant professor of pediatric neurology at King Saud University in Riyadh. He is the SPNS President, the IRB Chairman at King Saud University, and the National Delegate of Saudi Arabia to the Asian Caucasian Child Neurology Association. He holds a Canadian Fellowship in Pediatric Epilepsy and Pediatric Neurology from King Faisal Specialist Hospital and Research Center and Saudi Board of Pediatrics. It is unfortunate that Prof. Bashiri was not able to deliver the talk, but it is a big pleasure to welcome Dr. Osama Muzaffar, the SPNS representative for the Western region, to deliver the talk. Welcome, Dr. Osama.
Thank you. Assalamu alaikum, sabah al khair. Good morning, everyone. It is my pleasure to welcome you all on behalf of the Saudi Pediatric Neurology Society, the SPNS, on behalf of Dr. Fahad Al-Bashiri, to welcome you to this conference entitled the 10 Hot and Important Topics in Pediatric Neurology. This conference will cover really important and common topics to pediatric neurologists, to general pediatrics, to family medicine, and to general practitioners. It will go through epilepsy, neuromuscular disorders, rare diseases, developmental disorders, and artificial intelligence. I would like to thank our eminent speakers for coming and participating to this conference. I would like to thank you all, every one of you attending the conference in person and online. I would like to thank the endorsing societies, the Saudi Society of Family and Community Medicine, the Saudi Pediatric Neurology Society, the Saudi Epilepsy Society, and the Saudi Society for Neuromuscular Electrodiagnostics in Saudi Arabia. Also, special thanks to our sponsors, Medica, Biogen, and GSK, also to Multaqa Al-Khibrat for organizing this event. Special thanks also to Dr. Ashraf Amir for leading this conference, and Dr. Anas Al-Yazidi also for putting everything together and leading the organizing committee. Again, everyone, welcome and looking forward that you will enjoy a fruitful meeting.
Thank you, Dr. Osama. I hope everyone had his morning coffee to avoid headache as we will start our headache session. It is a big pleasure to welcome Dr. Tahani. Dr. Tahani is a consultant pediatric neurologist with subspecialty in epilepsy and EEG at the International Medical Center in Jeddah. Her interest to be a pioneer in pediatric neurology, in particular epilepsy and EEG, with an interest in evaluating patients admitted for epilepsy monitoring unit. Dr. Jamali has been Senior Chief Epilepsy EEG Fellow, graduated from King Faisal Specialist Hospital in Riyadh, and will be presenting a presentation titled Headache in Children, What's Benign, Concerning, and When to Refer. Welcome, Dr. Tahani.
Thank you. Thank you all. Thank you, Dr. Anas. Thank you, Dr. Ashraf, Dr. Osama, and everyone. I'm honored to be here among the esteemed speakers. Eid Mubarak to everyone. الله يجعلها إن شاء الله يا رب أعمال قبلت صالحة قبلت وإن شاء الله وحسنات إن شاء الله كتبت. Eid Mubarak to everyone. It's actually my pleasure to be here as to speak about this common presenting complaint in pediatrics, in which لا تخلو عيادة actually weekly basis, if not daily basis, to have such a complaint. And with the new emerging, inshallah, اللي هي extending in the age group that we're going to encounter more and more of seeing our beloved children having such a complaint and to help them through this journey. I will start with Bismillah ar-Rahman ar-Rahim. Nothing to disclose for me. The defined outlines, you see it from here. To start with epidemiology, approach and classification, red flags, and when to refer, which is the main topic for our title today, and to approach management, acute and prevention. As we mentioned, it's the new era, especially for headache. And at the end, we'll talk about the summary. So to start with defining headache, which is actually, I call it the invisible pain. It's pain or discomfort arising from the pain-sensitive structures, in which we have extracranial and intracranial structure at the schedule outlining here. We can see and we can check that extracranials consistent of multiple structures that can cause pain among these, especially the blood vessels, the skin, muscles, fascia, dental structures, and intracranially large arteries around the circle of Willis and large venous sinuses and dural arteries and parts of the dura. It's a most common complaint among children and adolescents, and one of the top and medical and neurological disorders contributing to global burden of the disorder and leading cause of disability. Actually, saying that, it's actually counting for about 12% of the population, and mostly before puberty, boys and girls are equally affected. But as we can notice, with time, girls and females are more liable of having migraine headaches and other types of headache, more percentage than the boys. If one parent is affected, we have an increased chance of 40%, and if we have both parents are affected, it increases the risk around more than 70%. And there are annual ER visits with acute migraine or acute headaches, with 3% encountering ER or emergency department visits. It started actually in the ancients, and previous civilizations has actually mentioned about headaches and different ways of treating it. Thank God it's not anymore now. We still have the lumbar punctures, but not the previous treatments as like drilling the skulls and others. But it was first noticed and published in the Lancet in 1964 by the author and critic Susan Sontag, who published a little-known short story entitled Man with a Pain. And it's an eloquent reflection not only on the difficulties actually patients face when attempting to communicate invisible forms of pain to others, but also on the struggle that witnesses to their suffering experience in expressing sympathy. Approaching is just to head to the approach. We have multiple things to diagnose headaches. We start with classification just to make a clear idea of what we are going to encounter during history taking and physical examination journey. To start with, actually, it is based on the 2018 International Classification of Headache Disorders, 3rd edition until the moment. But saying that, there is a work in progress which has been still ongoing with some enlightenment of other classifications to be approached, which is still on the phases. To start, there are actually 3 parts where we can define and classify headaches, in which the primary headaches consistent of the 2 top presentations of migraine and tension type headache, and also the trigeminal, others like trigeminal autonomic cephalgias, other primary headache disorders, the secondary headaches in which we are going to encounter later on with the red flags, headaches attributed to trauma or injury or to cranial or cervical vascular disorders or non-vascular intracranial disorders, substance or its withdrawal attributed to infection, headache attributed to disorders of homeostasis, and headaches of facial pain attributed to disorders of cranium, neck, eyes, ears, nose, sinuses, teeth, mouth, or other facial or cervical structures. Others cause like neuropathies and facial pains and other headaches, and they're usually painful lesions of the cranial nerves or other facial pains. Start with the most common presenting. Among the 12%, 8%, and up to 80% in pediatric neurology practice, usually migraine is ubiquitous and is diagnosed of all the headache encounters. And this is unsurprising given that the migraine is highly disabling and very common, and we see it even in younger ages nowadays. The diagnosis of migraine remains a clinical diagnosis as no reliable biomarkers exist. So the history, mainly headache medicine, relies heavily on patient's history, perhaps more than any other field in neurology. And while laboratory tests and imaging studies actually assist in diagnosing secondary headache disorders, but mostly and all headache disorders are diagnosed largely by history. So actually, this is like a barcode. If you want, you can have in your clinic, if you have patients, in which to start with the onset of headache and the frequency, for how long does it last, and where is it located, how does it look like, and aggravating factors, decreasing factors, any medications have been used before, any relation to food, any relation to light sensitivity, which we call photophobia, any smells, like any noises, like sensitivity to noises, like phonophobias, and other associated symptoms. For the follow-up, actually, it's a more like of a summary of what happened since the last visit, and keeping a diary always with the patient and giving them an advance or like a recommendation for keeping a diary of headache to help them and to help to guide what's going to happen for the treatment, and to reach to the risk factors that causes or mostly cause or aggravate the headache. For the international classification of headache disorder, we will just like enlighten here, and we actually mention of like, especially for migraine, to differentiate between migraine and the tension type headache. As we can see, at least for the migraine diagnosis, at least 5 attacks fulfilling the criteria from B through D, which is headache attacks lasting from 34 to 72 hours when untreated or unsuccessfully treated. And headache has at least 2 of the following 4 characteristics: unilateral location, pulsating quality, moderate or severe pain intensity, and aggravation or causing avoidance of routine physical activity by walking or climbing stairs. And during headaches, at least 1 of the following: the presence of nausea or vomiting, and photophobia or phonophobia. For the tension type headache, at least 10 episodes of headache that are usually occurring on less than 1 day per month on average, or less than 12 days per year, and fulfilling the criteria from B through D. Lasting from 30 minutes to 7 days, and at least 2 of the following 4 characteristics. Usually it's actually described as bilateral location, or some they will mention it's like a band-like, and pressing or tightening, non-pulsating, like the migraine. Quality, mild or moderate in intensity, and not aggravated by routine physical activity such as walking or climbing stairs. And both of the following: no nausea or vomiting, and no more than photophobia or phonophobia. We have to mention, saying that we have to mention some of the syndromes that are associated and can contribute to the diagnosis of migraine or headaches, in which there is like a big relapse between abdominal migraine, benign paroxysmal torticollis, benign paroxysmal vertigo, and cyclic vomiting syndrome, recurrent gastrointestinal disturbances, in which the frequent ER visits when patients of pediatric age, they come with abdominal pain. Saying that we have to have at least 5 of the recurrent attacks, and the patients will be completely healthy in between these attacks. Each one of these has different numbers of attacks. The other things is to actually also make an approximate diagnosis for differentiating between the cyclic vomiting syndrome and also the well-known occipital lobe epilepsy, which is called Panayotopoulos. So it's very important to diagnose in order to reach the treatment and management. From approach reaching to physical examination, actually, it's very important to say that vital signs and growth parameters are very good encounters to have on this topic, as hypertension, prostatic hypotension could be a leading cause to headache, significant weight loss or obesity for like space-occupying lesions, and obesity for idiopathic increased intracranial pressure, and fever with meningeal signs, knuckle rigidity, cranial nerve examination with fundoscopy on examination for papilledema, and standard motor sensory and coordination and gait exam. Auscultations, the use of stethoscope, yes, in neurologists we use actually, it's auscultation to the neck, orbits, and temples for bruise, and it may signal underlying turbulent flow through craniocervical vasculature associated with underlying vascular disorders, especially in Sickler's and Moyamoya disorders. Palpation of cervical musculature useful in identifying trigger points which commonly occur in trapezius in children and adolescents with migraine, and palpation of sinuses, as it's a common presentation also in pediatric age. The investigations, as we have addressed that, it's mostly recommended for addressing or like distinguishing secondary type of headaches. And blood investigations like CBC, basic metabolics like electrolytes, inflammatory markers like CRP, ESR for infections, and lumbar puncture with measure of opening pressure and idiopathic increased intracranial pressure, and neuroimaging, specifically superiority of brain MRI, but in emergency setting, brain CT. And here is like the most important of this topic. I would like to tell you about the mnemonic in regards of the red flags for the headaches. This is actually more of like adults, but we have here for the pediatrics, which is Snoopy is wet. It's a cartoon, and it rains over these cartoon characters. So S stands for systemic signs and symptoms. You can see here systemic signs and symptoms attributed to infection or non-vascular intracranial disorders or carcinoid or chromocytoma. And neoplasms in history, if there is neoplasms of the brain or metastasis, and neurological deficit, including decreased consciousness, which is related secondary headache attributed to vascular, non-vascular intracranial disorders, brain abscesses, and or infections. Onset of headache is sudden or abrupt, which we call it thunderclap headache, which is the most severe headache that is presenting, which might indicate subarachnoid hemorrhage and other headaches attributed to cranial or cervical vascular disorders. Here it says older age, but in the pediatrics, actually it's more like of a younger age, less than 3 years of age. And pattern changes, recent onset of headache, positional headache, of course, which indicates intracranial hypertension, precipitated by sneezing, cough exercises, which might indicate posterior fossa malformations or Chiari malformations, which are associated mostly with headache. Papilledema, the presence of papilledema, which may indicate space-occupying lesions and others. Progressive headache and atypical presentations, and painful eye with autonomic features. Post-traumatic onset of headache, and painkillers overuse or new drugs at onset of headache. So infective, new neurological symptoms, occipital headache indicating or attributing to a space-occupying lesion or Chiari malformations, waking from sleep, early morning vomiting, and thunderclaps. So this is also a very important slide in which when to refer headaches, if it's a severe or sudden or severe over minutes to hours, like an instant thunderclap, we have to have an immediate referral to call the ambulance and to call the ambulance. The possible causes could be subarachnoid hemorrhages with which until proven otherwise, and if associated with fever, as we have mentioned, it could attribute to meningitis, craniocervical artery dissection, venous sinus thrombosis, or stroke or hemorrhage on unilateral eye pain. This is a high-risk headache syndromes, and these presentations carry high potential risk of serious underlying pathology and acute major neurological morbidity. The other type is subacute, severe hours to days, which if we have like focal neurological signs, it would be attributed to the, or classified with the severe type of headache. But if it's no focal neurological signs, we have cerebral imaging to be done, like brain CT without contrast or MRI, depending on the clinical scenario. And may discuss with the neurologist or referral here and early referral to a neurologic for other further workup. The possible causes could be of tumors, cerebral abscesses, accelerated intracranial hypertension, idiopathic intracranial hypertension, intracranial hemorrhage, subdural, post-traumatic or venous sinus thrombosis. This is an immediate risk headache, and these presentations can carry a high risk of major neurological morbidity if a definitive diagnosis and specific management is not promptly instituted. The other is like if we have subacute severe hours to days, but it's tender temporal artery. This is more like of an adult age group. The other is recurrent or chronic persistent or daily. Family physicians management, routine referral if needed. Possible causes, as we have mentioned, classification of headache syndromes like migraine, tension type headache, medication overuse, cough, and others. This is actually of a low risk headache, and generally these headaches align with a pre-existing and often long-standing history of relapsing intermittent chronic daily or acute relapsing on chronic headache, and rarely signify serious underlying pathology and rarely carry a risk of major morbidity. Reaching to the management, as we know, and we all know, prevention is the most important part of management in regards of headache management, as to being away from the provoking factors usually help a lot of patients in reaching more of control to their headaches. But this is a summary of recommendations from the American Academy of Neurology guidelines on the acute treatment or management of migraine in children and adolescents. بس طيب هو صراحة it's a big topic. I usually encountered like conferences with two divisions of the topic, approach and then the management, but we'll try to go through quickly. Okay, so the main goal for addressing the acute management is appropriate care requires specific headache diagnosis, acute migraine treatment, need for fast and complete pain relief, acute migraine treatment, need to treat individual headache characteristics, for adding non-steroidal anti-inflammatory drugs or triptans if there is no cardiac contraindications. Acute migraine medications may not treat nausea and vomiting, so the addition of antiemetics is very helpful. Patient education around behavioral aspects or self-care can improve outcomes. Triptans have, as we mentioned, cardiac, if no contraindications with cardiac disorders. There are just new modalities of 3 non-invasive neuromodulation devices cleared from the US FDA. Can go through the, this is like just like an example of examples of like many routes for developing or like giving the triptans. Summary of prevention treatment from the American Academy of Neurology, saying the summary of recommendations, identifying very importantly lifestyle and behavioral factors which play a major role in disease management. Patients with frequent or severe headaches should be offered preventive treatment. They used to say more than 15 attacks per month, but disabling, school absences, and others. There is some evidence of pharmacological intervention and cognitive behavioral therapy in the preventive treatment of children and adolescents with migraine. Migraine is a chronic disease, and here like summarization of the medications and suggested doses to start. We have مرة خلاص بس واحدة دقيقة. طب نروح على السمري. Comorbidities of primary headaches, we have anemias and other things. So headache is one of the top medical and neurological disorders contributing to global burden of the disorder and leading cause of disability. Classification is based on the approach, history, physical examination, red flags and referrals, and this is just to remind you about the red flags and when to refer. And mostly it's attributed to like secondary type of headaches. Prescribing effective acute treatment is a consistent best practice and may mitigate the risk of disease progression and help in the disease progression. Clinical trial data suggests approximately 2/3 of children and adolescents with migraine will achieve treatment goals 50% or greater in reduction of headache frequency using pill-based preventive intervention. And preventive treatment should be offered to children and adolescents with migraine who are experiencing attacks at a frequency or severity that is leading to significant disability. Other treatment modalities like interventional neuromodulation should be considered. While pediatric clinical trials are underway, there are expert consensus guidelines and guide clinicians in when to consider off-label use of anti-CGRP monoclonal antibodies. And at the end, to conclude, we have to mention these two important points in which psychological interventions have significant body of evidence to support their use and should be considered as potential first-line interventions in combination with pill-based interventions. Although evidence in this area is limited, there should be counseling on the relationship, daily headaches, and poor sleep, obesity, meal skipping, particularly breakfast, and low physical activity. Thank you.
Thank you so much, Dr. Tahani. Very comprehensive and engaging talk with nice algorithms to approach headache. We can take a couple of questions for Dr. Tahani if anyone has any questions. Prof.
Bismillahirrahmanirrahim. Thank you very much, Dr. Tahani. Very comprehensive presentation, and it's a big topic. But I just wanted to stress one point. Many times, many of the children that we see, the visit to the neurologist is the treatment, more or less. So many families, they're alarmed, they're worried. So when they come, you examine the child, they feel reassured. Maybe as close as 60% of patients, we never give any medications. This is one of the other things about the treatments. There is a strong placebo effect in pediatric headache. So even people have used vitamins, riboflavin and things like that. So whatever you give, there is a good chance headache will go away because the parents are less anxious. So this reflects typically to the child and the headache resolves.
Thank you, Prof. Akid, well taken points. And yes, I receive during even a busy clinic referrals from my colleagues to have children who's having headaches. And when they come and encounter everything in regards of history, taking many points and trying to reach, working as detectives of what's really going on. And many, they turn out to be, as I mentioned in the last slide, actually it's like a neuropsychological behavior, more like that. And usually it's the fast lifestyle, others, the burden, some are engaged in many activities during the day, having full activities that might contribute to the increase of burden and headache. Yes, of course, I totally agree. Thank you, Prof.
Okay, any other questions? Dr. Ashraf?
Thank you so much, Dr. Tahani, for this wonderful presentation. I would like to highlight a problem that always happening in primary care, the medication overuse headache because of the overuse of NSAIDs and triptan. So what is your advice to reduce this kind of complications, and what is the future of using the CGRPs and GPANs in this kind of, knowing that now the age up to 18 years, so definitely there will be some kind of adjustment of our way of practicing medicine and managing patient with migraine. Thank you.
Thank you, Dr. Ashraf. For sure, yes, the new modalities, especially with the larger age group, especially I did not mention like more than 12 years of age, there are a clearance from the US FDA of having non-invasive procedures, like the non-invasive VNS, for example, like transauricular stimulation, like it's an outside devices of stimulating the trigeminal nerves, just to make like a low threshold of pain to encounter more release of the headache, to avoid and to treat the headache as an acute one. For the overuse medications, actually part, thank God it's in pediatric age group, more of a control of the parents. And especially when the parents, they come, they actually avoid having the overuse of medication. Probably it's more of a problem like in adults, like who have in reach more of like these medications. But as Prof mentioned, we have like a less frequently prescribed and this very disabling headaches prophylaxis. And saying or mentioning side effects as amitriptyline is prone to suicidality, others could make some of the parents' counseling more appropriate, saying that we have like we face more side effects, liver injuries, like we give them this counseling during the clinic, and they try to minimize the use or overuse of the medications. Thank you.
Thank you so much. Now, without further ado, we will move on to the neurodevelopmental session. But before we start, we have a quick live debate questions. If you all may scan your QR codes, and we're going to see our answers together, just to make the session interactive. Sure, it will start. It should start. Okay. لا, this is the first. So the previous question was for the headache session, and that we skipped it. Now these are for the neurodevelopmental session. So should ADHD medication be initiated in primary care without specialist input? What do you think? Yeah. 1 minute to show this. I'll show you. So I think every pediatric neurologist said never, so they have customers to their clinic. Okay, so moving on to the next question. Which is the most common reason for ASD diagnosis is delayed? Which one of the following do you think it's going to be delayed usually? Show answer. So an overwhelming answers for parental denial, always blaming families. Okay. So have a next question, or that's it? Do we have? Dr. Ahmed is a consultant and associate professor of child neurology, adult and pediatric neuromuscular medicine. He is the head of the pediatric neurology unit at King Abdulaziz University, a pediatric neurology consultant at Salama Hospital, and a master degree candidate in pediatric neurodisability. He's a member of the National Neuromuscular Committee at the Ministry of Health and the Saudi Scientific Committee for Pediatric Neurology in the Saudi Commission for Healthcare Sciences. He actively engaged in clinical care, education, national research collaboration with a professional interest that include precision medicine, neuromuscular disorder, neurogenetic, advanced neurophysiology, and multidisciplinary care models. Dr. Ahmed will present a talk on ADHD and ASD in primary care with a practical assessment for GP. Dr. Ahmed, welcome.
السلام عليكم صباح الخير جميعا وكل عام وانتم بخير والعيدين الفايزين يا رب. So this is actually a second hat. I usually wear my neuromuscular hat, but today I'm going to wear my neurodevelopmental hat. So what we're going to talk about over the next 20 minutes plus or minus is neurodevelopmental disorder. So I tweaked the title a little bit. I'm not going to only talk about ASD, autism spectrum disorders, and ADHD. I'm going to just have an overview of the all neurodevelopmental disorder that we face in the clinic. We as a pediatric neurologist, child psychiatrist, and developmental pediatrician. So it's just an overview. I'm not going to go into deep details about every single aspect of every single condition in neurodevelopmental, but if we have time later, we can definitely sit and discuss. So what are these neurodevelopmental disorders? These are conditions with onset in developmental period. We talk about infancy or early childhood, characterized by deficit in personal, social, academic, or occupational functioning, and they typically persist during adulthood, not necessarily, but typically they do continue during adulthood, but the severity might change. You have seen on autistic children who are quite severe in younger childhood, might be a bit better when he grow older. Same thing with ADHD. We don't typically call it ADHD in adulthood, we call it ADD, so they don't have this hyperactivity part of it. So that's, things might change, but typically the disease, the condition itself might persist. And they don't come alone, they come together, so they do co-occur together. So you might see a patient with ADHD plus autism, intellectual disability plus epilepsy, tics plus ADHD, so you might see a couple of conditions coming together, so it's not necessarily one single condition. So why we need to talk about these neurodevelopmental disorders? Actually, they are the leading cause of childhood disability worldwide. If you think about the numbers, so more than 15% of children, they're affected with autism, according to the CDC statistics. And if you think about ASD, in particular, autism spectrum disorders, we have more than 1 in every 36 in US child affected with autism. And if you think about ADHD, up to 10%, like out of 100 children in a specific school, you might have 10 children affected with ADHD. So it's really quite a huge number of patients or children, they are actually suffering from these conditions. They do have significant impact on families, schools, society. So up to 70%, 75% of families with autistic children, they ended up with a divorce. 50% they have a single mom in US. So it's really quite significant. The third point is early identification might actually lead to enables effective intervention. We all understand that early intervention is actually cornerstone management piece for those patients. Multidisciplinary approach is very important, and with increased awareness, we're seeing more and more of those patients. So the number and the prevalence actually is going to keep getting larger and larger with time. Starting with the case, so this is a 6-year-old boy I've seen in the clinic. So he had a mild developmental delay, hyperactivity, speech difficulties. He does communicate verbally, but is not very up to his age. He has a fair hair color, important physical finding on exam. The rest of the neuro exam was normal, slightly overweight, but that's it. He had 2 older sisters with speech delay, intellectual disability, hyperactivity. The oldest, I think, the eldest, she is 20, then 14, and he's 6. Parents are first-degree cousins from Yemen. So what do you think? I mean, this is a patient with hyperactivity referred to the clinic with hyperactivity and speech delay, but they have this significant family history and maybe some abnormal finding on exam. For the sake of time, so what do you think? I mean, do you need to do genetic testing? If yes, do you think he might have phenylketonuria, homocystinuria, Lesch-Nyhan syndrome, or Krabbe disease? I mean, I just listed a couple of diseases there. So I think for family physicians or general practitioners, we don't typically do genetic testing right away when you see patients in the clinic with neurodevelopmental disorders, but we have the red flags in the family history or an exam. Maybe genetic testing might be used for this patient. Actually, we ended up doing genetic testing. And the second page, I mean, the first page was negative. The second page, they mentioned that the patient is a carrier for, he carries homozygous mutation in phenylketonuria. So this patient ended up having phenylketonuria, milder phenotype with only behavioral symptoms, no other phenylketonuria related symptoms, and both of his sisters confirmed to have, and they have one another child or a sibling who is healthy, and he does not carry the mutation. So yes, you might see a genetic/metabolic disorder that presented with ADHD symptoms. Another quick question, so a 3-year-old present with global developmental delay, hypotonia, and self-mutilating behaviors. Which metabolic disorders should be suspected? I mean, this is an exam question. I have seen only one single case of this condition. So Lichtenstein with the self-mutilating behaviors should be considered. But again, the reason why I brought up these two cases, yes, we do see some genetic metabolic conditions. They might present with behavioral symptoms as a primary symptoms in addition to other neurological features. Okay, so we start with the first neurodevelopmental disorders, intellectual disability. It used to be called صعوبات تعلم. It used to be called the cognitive impairment or mental retardation. So these actually now it's lumped together as intellectual disability. To define a patient with ID or intellectual disability, he has to have an IQ less than 70. IQ test, we're going to talk about the test in a second, but you have the table here. So if you have a patient with an IQ between 50 to 70, that's minimal, or mild developmental delay or a cognitive delay or intellectual disability, moderate between 35 to 50, severe less than 35, and profound less than 20. Now, why it's important, you guys are dealing with the Tahil Shamil. So Tahil Shamil, they started to accept only less than 50. If your patient or family, they are seeking some support, funding support or financial support from a Tahil Shamil, they have to have 50 or less. It used to be 70, now it's actually they went it down or took it down to 50. Now, how we test the IQ is actually done by a psychologist. I'm not going to go through every single assessment here, but the first two here, the first one, the WISC-5, Wechsler International Intelligence Scaling Score, is actually the most commonly used preschool or school age, so between 6 until 16. It's done by a psychologist. It takes it between 2 hours to 3 hours to do it completely and perfectly. The problem here in the practice, you might see actually WISC-5 in a 2-year-old or 3-year-old. That's completely not practical, doesn't make a lot of sense when you do this test in a younger than 6-year-old. The second one, Stanford Binet 5, that actually is done for younger patients, like 2 and above, 2 years and above. So that you might see it actually in the clinic, and that's okay to be used in younger patients. And actually, that's the whole point of Stanford Binet, is to do it in a younger patient, 2 years and older. Now, what they do or what they look for is they look for visual, spatial comprehension, speech, fluency, and other domains, and like knowledge and others. So these are the things that they look for when they do these kind of assessments. They're questionnaire based, and plus some questions that the child or the patient is supposed to do it. Be careful when you do it for a non-verbal patient. Be careful when you do it for a patient with ADHD, because they might lose points just being inattentive. So a specialist should be aware of what he's testing and what is he looking for. Now the others, Ravens, Metrics, Woodcock, and Kofan, it's not commonly used in Saudi Arabia, but you have it out there. Some centers, they might do it for IQ assessment. So that's the first one. Is intellectual disability, is commonly co-occurred with other neurodevelopmental disorders as well as genetic and neurogenetic disorders. So something to keep in your mind. And if you want to help your child or your patients, Tahil Shamil, they do require specific testing. They do require the numbers if it's less than 50 to provide the financial support. Now, the second disorder that I'm going to talk about is communication disorder, صعوبات التواصل. So it used to be lumped with autism. Now it's two different diseases or conditions. So صعوبات التواصل is the second one that we're going to talk about. Under صعوبات التواصل, under the communication disorders, we have a couple of conditions that we need to focus on. The first one is language disorder, صعوبات التخاطب. So when it comes to the language disorders, it can be structural, like patient, they have some sort of structure, cleft palate or trauma, or can be neurological patient with the genetic conditions or some problem with the speech center. So when you say language disorders, it's really difficult in acquiring they use the language, so either receptive or expressive. That's the first one, and that's commonly seen in patients with epilepsy and neurogenetics. Speech sound disorder, these are the articulation problem. You commonly see it with a patient with cleft palate, patient with trauma, or patient with the neuromuscular conditions where they have actually nasal speech or phonation problem due to the weakness in the airways muscles. Childhood onset fluency, that's the most common language or communication disorders. Is stuttering is being the best example there, tata, but it can be not just stutterings, it can be blocks during speech, prolongation, as-salam, so it might take time to take a specific word, and speech pathologists or speech and language pathologists, actually they're the best people to deal with that. There are campaigns where they help those patients with stuttering. Always look for anxiety as a possible co-occurring disease with those patients with the stuttering. The last part, or the last condition under the language or communication disorder is social pragmatic communication disorders. And in a single word or a simple word is they don't understand the اللغة المجازية, so they don't understand the pragmatic language. If you say like أنا بموت من الحر, they might just understand that yes, you might actually die, or they commonly use this. It's raining like dogs and cats outside. That's the common example they use in the textbook. They think actually there's dogs and cats coming down from the sama. So that's what they look for. And how you use that practically, the child does not understand the language, or the pragmatic language, in the school. So the المدرس, for example, the teacher is saying like, if you do this, if you don't stick to your homework, I'm not going to teach you anymore. He believes that the teacher is not going to teach him anymore, or he's not going to allow him to come to school, and that might create problems. So these are the 4 conditions under the communication disorders. Now, it's really important to differentiate between autism spectrum disorders, and communication disorders. The main differentiating factor or point is with autistic children, they do have commonly communication problem, but they also carry the repetitive behaviors that we're going to talk about in a second. So those patients with the communication disorders alone, they don't have the typical fixated interest and the repetitive behavior that you commonly seen in autistic children. Now, ASD, the big topic here. So just an overview. So if you want, actually ASD deserves a full separate conference to talk about ASD and ADHD. But in summary, so if you want to diagnose a patient with autism spectrum disorders, the patient has to have a problem in 4 domains. The people might add the 5th, but we'll talk about domain A, B, C, and D. So domain A is the patient should have persistent deficit in social communication, social interactions across multiple contexts. Under this domain, there are 3 elements. So communications. So the patient does not have a problem with communication back and forth with others. Interaction, that's the interaction communication with the eye contact. So they don't have poor eye contact or body gesture. And also they have difficulty with relationship. They cannot start or establish a relationship. And the patient has to have all the 3 problems, or the problems in each 3 domains or points, social communication, interaction, and relationship. Domain B, so restricted repetitive patterns of behaviors, interests, activities. The patient is supposed to have 2 out of 4 under this domain. So the problem with restriction, so they have restricted behaviors, like rituals, he does it all the time. Repetitive behaviors, hand flapping, chair rocking, those kind of repetitive behaviors. Interests, fixated interests, he has to play with a certain toy, السيارة الزرقاء لازم هي نفسها. So these kind of fixated interest. These are the things that, or hyper and hypo. The 4th one is hyper and hyposensory response, or the sensory integration, where actually they get very excited or agitated when there is like a loud noise, like المكيف, المكنسة, these kind of things. So the patient has to have 2 out of 4. We're not going to go into details, but these are the diagnostic criteria, DSM-5. Domain C is the symptom present in early developmental period, they say before age of 5. And domain D, symptoms cause clinically significant impairment. And domain F, actually it's not better explained by other neurological or genetic problems. So this is ASD. Now, few points here. Most of the patients actually either overdiagnosed with autism, and that we see it all in the clinic all the time, or underdiagnosed. Two, they have a very big parents' denial, so they don't like their child to be labeled as autistic because they know autism is actually might be a lifelong condition. It will carry the difficulties around the children or dealing with a child with autism. So you do see these kind of things in the clinic, and it's not uncommon actually. 1 in 36 in US, and slightly more common in male than female.
5 minutes.
So red flags for practitioners. So by age of 12 for autism, if you have no bubbling, no pointing, no waving, that's something to keep in your mind. By age of 1.5, if there is no single words. By age of 2, no 2-word spontaneous phrases. At any age, if there is loss of previously acquired language or social skills, and again, at any age, if there is absent or limited eye contact, you have to think about autism. At least refer a patient to a specialist or a center where they can do this autistic assessment. Now, diagnosis. So it's a clinical diagnosis supported by a couple of questions or questionnaires or assessment tools that we do. Clinical history is very important. The first 2 cases that I presented where they have some symptoms similar to autism, so please take a good full history, family history, and social history. Screening tools. So none of these actually is commonly used in Saudi. The one is supposed to be, instead of CAST, is CARS, Childhood Assessment Scaling Test score. That actually is out of 30. Less than 30 is not autistic. More than 30 is autism. It's just a screening tools commonly used above age of 4. Which is actually it's an okay score or assessment tool, screening tool that can be used by centers like early intervention center. Now the gold standard is EDOS, which is, again, some center they do it. I'm not going to promote any center that they do it here, but EDOS actually the most commonly done gold standard diagnostic tool for patient. EDOS 2, Autism Diagnostic Observation Scoring System 2. Vinland Adaptive Behavioral Scale, some center they do it. It does carry some importance for autism, but also it has some adaptation, ADHD-like questions, so it does carry both or help you with both ADHD and autism. Genetic disorder or autistic features, please keep that in your mind. Fragile X, I just had a patient last week with Fragile X with autistic features. Tuberous sclerosis, they might have neurodevelopmental problems. Other disorders like Rett, Angelman, and Beaton related disorders. So something to keep in your mind when you see those patients. In terms of management, as up until now, there is no cure for autism, but we might help your patient with behavioral and educational assessment, communication therapy, occupational therapy, especially sensory integration, pharmacological if they have symptoms associated with ASD, like irritability, you can use risperidone, aripiprazole, ADHD symptom, you can use methylphenidate, Vyvanse, amphetamine, and others, anxiety, SSRIs, and sleep, you can use some sleeping medicine. So these kind of things that you might help. I'm not going to talk about folinic acid. I mean, I think we need another lecture for leucovorin, but that's something to keep in your mind. Now, which of the following is characteristic feature of Landau-Kleffner syndrome? That's for non-neurologists. So I think we have only 3 minutes left. So regression of the speech. So that's one thing that we think about when you see a patient who lost his speech and he has seizures, to think about Landau-Kleffner or acquired epileptic aphasia. But again, the reason why I brought that up, we don't typically do EEG for every single patient who has speech problem in the clinic. ADHD, very quickly. So ADHD is quite common, 10%. In the clinic, they have either inattentive type or hyperactive type or combined type. It's really difficult to deal with a child with ADHD in the clinic. If you are a teacher, they like to deal with autistic children, but not ADHD, because actually they just hyperactivate the whole class. Be careful with ADHD because they commonly exist with other diseases, including ODD, oppositional defined disorders, which is very difficult to deal with in the clinic, especially in a teenager. And now we're expanding the age to 18. We started to see more and more of those patients. You guys can read about the diagnostic criteria. It's very long. You don't have to have every single element here, but if you go through it in your own time, you will see they have very typical symptoms of either hyperactivity or an inattention or a combined features. Management, again, similar to ASD, behavioral symptoms, behavioral management, and that should be the primary management for any patient less than 6. Then, and that should be in school, home, as well as environment, general environment. Then we have the medication, including stimulants and non-stimulants like tamoxifen, and psychological support at the school. specific learning disorders, so that we're gonna just power through it very quickly. So we have dyslexia, that's very commonly overdiagnosed in the clinic. Patient with the reading problem, they just label him with a dyslexic, as a dyslexic. So dyslexia is the difficulty with reading accuracy. They switch, they read upside down, they read from left to right instead of right to left. These kind of things, B and D, P and Q, these are kind of difficulties. Dysgraphia, where they have actually written expressions, so he cannot write properly. Dyscalculia is a math problem, so a particular math related problem. So it's something you keep in your mind. Dyslexia is commonly associated with other neurodevelopmental disorders, so keep looking for that. And there is management tools for dyslexia where patient can help them to deal with it, or at least how to deal or live with dyslexia. We have successful people in the society where they have dyslexia, but they're actually, I think one of them is Mudia Akhbar, so he's dyslexic, but he's actually a news expert. So that's something to keep in your mind. Motor disorders and tics, so that's something to keep in your mind when you see a patient in the clinic. So tics is very commonly seen in neuroclinic. It's considered or as a place under movement disorders as well as neurodevelopmental disorders. So that's something to keep in your mind when you see a patient with tics. Not every single tics requires treatment. Even the treatment is not, 50 to 80% depends on the tics that we are reading. But something to keep in your mind, look for underlying anxiety, look for any bullying at school, look for other social triggers for tics, as well as ADHD and anxiety, as I mentioned. Tics we divided as simple and complex, depends on the semiology, and in terms of duration we call it transient, chronic, or Tourette, which is the more severe phenotype of motor disorders. Before I move to stereotypes, there is an interesting syndrome or condition that's called childhood incoordination syndrome or childhood clumsy syndrome. It's commonly encountered في العيادة. الطفل بس ما عنده أي مشكلة. He has difficulty with performing his daily activities in a right way. يعني الطفل بالعام يأهوج أو يطيح يخبط في الأشياء يضرب في الأشياء. So something to keep in mind. Actually, some occupational therapy will help that children. Sometimes I just suggest to go to gymnastic or karate or any martial art that will help those families. Stereotype is similar to tics, but is younger patient age group. It might carry some neurological consequences. It might be associated with other neurogenetic conditions. So something you need to refer to a neurologist. Will he need to follow the patient and decide whether it's actually stereotypes or autism or tics, whether he needs to do further investigation or not. This is the Rett syndrome, so it can look like an autism. So she has this chair rocking, but she has all the other features. She has epilepsy, she has movement disorders. So it's not just repetitive behaviors. Actually, she has more than just a repetitive behavior. So something to keep in your mind when you see a patient with very severe behavioral problems associated with epilepsy, regression. Think about genetic condition that might look or mimic autism. And this is, I think, the last slide or the one before the last slide is they always do co-occur together. So look for ADHD and ASD. They do occur up to 50%, autism and epilepsy up to 20 to 30%, intellectual disability and epilepsy up to 30%, and so on. So something to keep looking for when you see a patient with one single neurodevelopmental disorder. Because if you're going to treat this patient or help this patient, you have to look at him as whole, not to tackle one condition only on one disorder. You have to make sure you're tackling all the aspects of his condition. So these are the key takeaways point. I'm not going to read it. You guys can go over it at your time. I think I'm already over, so I will stop here. Thanks, and I hope we can meet again, talk more in details about every single disorder. Thank you.
Thank you so much, Dr. Ahmed, for this comprehensive talk. Your phone. Thank you. Thank you for emphasizing even the social struggles that those patients encounter, which is often overlooked. Now moving on to the next talk, it is a big pleasure to welcome Dr. Ghalia Yazidi. She's a consultant pediatric neurologist at King Abdulaziz Medical City, affiliated with the National Guard for Health Affairs in Jeddah. She's the Program Director at King Abdullah Children's Specialist Hospital here in Jeddah. She obtained 2 subspecialty fellowship degree in electroencephalography and neurometabolic at the University of Toronto, Canada. Likewise, she attended her fellowship degree at the Royal College of Physicians and Surgeons of Canada. in neurology. She did a residency training program in pediatric neurology in Montreal, Canada. Dr. Ghalia will present a talk on supporting family after a life-changing neurological diagnosis. Welcome, Dr. Ghalia.
Assalamu alaikum, everyone. It gives me great pleasure to present today, and a special thank to the scientific committee for the invitation. My talk will be about supporting families through challenging neurologic diagnosis. Being a neurologist and a neurometabolic specialist, I tend to work with a lot of families who have progressive or neurodegenerative conditions, so we'll try to see how we can support them through the primary care point of view as well. So first, I'd like to have the view of the group of what would be the appropriate action over two common classic scenarios that we see in neurology. So the first is a 6-year-old boy who has mitochondrial disease. He's 6-year-old, but he's behaving at a 2-year-old level. He has severe dystonic posture and irritability, and that's a new change from his baseline. So let's think and see, maybe with a show of hands, what would be the appropriate action in that scenario. So should the physician consult neurology and see if they should escalate treatment and treat the dystonia alone? Should we consult complex care for palliative care at this point, since it looks like it's a progressive illness and the child is not doing so well? Should we evaluate for pain or systemic causes? Or should we admit and do the full thorough workup? So let's see with a show of hands, who would go for A? Okay, so who would go for C? Yeah. Okay. A second case is a 10-month-old boy who's known for global developmental delay. He's behaving at a developmental age of probably 4 to 5 months of age. He had new onset infantile spasms, diagnosed 2 weeks ago, so obviously the workup is still being done, and we do not have a confirmed diagnosis on him yet. He's admitted to the PICU with severe aspiration pneumonia, and he had a provoked status epilepticus as a consequence of the infection. During the family discussion, the ICU is approaching the aspect of limitation of goals of care, since the child does not look like he's doing well so far. So the family is asking, is still hope for him? Is he gonna do well? Do we know what's the diagnosis, or what should we expect? So the options could be supporting limitation goals of care, requesting time for neurologic diagnosis and clarification and prognostication, so allowing more time for diagnosis and prognosis, arrange for a multidisciplinary discussion with neurology, have everyone on board, see what do we think, where we are so far, or focus on treating the acute illness now and then look at the other aspect of the illness after. So again, in a show of hands, who would go for A? I do not need to continue with the talk then. What about who would go for C or A? Yeah, excellent. So the objectives of the talk will be to understand the family impact of neurologic diagnosis, clarify the pediatrician or the family physician role in managing and coordinating the role of the patient of the care, to try to apply structured, strength-based communication strategies that improve the connection with the family and improve the outcome and improve the general health of the patient, and monitor and manage common medical comorbidities. So neurologic disorders are chronic conditions that have a lifelong implications. They carry a lot of uncertainty and unpredictability throughout the course of the disease. At initial diagnosis, there is a major stressor compound to the family, and that's mainly due to the uncertainty and the implication of a diagnosis. Long-term outcome is hugely influenced by the continuity and coordination of medical care, optimizing the general health of the patient, preventing recurrent infections. That is a major aspect of the care of those patients with neurodegenerative conditions. And that takes us to having a proactive rather than a reactive role in the care of those children. So being a neurologist unbiased, I think neurology is very fascinating, and that's mainly because of the complexity. And the complexity will take us through different factors. So first, developmental dynamics. So the patient might be normal at the initial diagnosis or after a brief period of regression, but has a diagnosis that will actually manifest as the child goes older. Regression might happen at any point. It might improve or stabilize depending on the general condition of the patient. There's huge phenotypic and genetic variability and overlap. So movement disorder or epilepsy or microcephaly can be a presentation of several disorders. At the same time, one genetic mutation can present with several manifestations, and also for the same family, they can have different symptoms. Let's say a patient with mitochondrial disease, for instance, will have developmental regression, dystonia, seizures. In the same family, if you look at the pedigree, there will be someone with sensory hearing loss, there will be someone with neuropsychiatric features. So that makes the understanding of the disease, the acceptance of the disease sort of challenging to the families and to the physicians involved in the care of the patient because of the variability. Imaging ambiguity is another major factor. So MRI can be normal in the beginning of the diagnosis or can actually be quite abnormal, but the child is relatively better than the imaging. Again, in certain neuroinflammatory condition, the child will improve, let's say if it's ADEM or childhood onset MS or MOGAD, the child will actually improve, but the MRI will still be abnormal. So are we treating the MRI or are we treating the child? And there's the contextual and systemic factors. So the child will tend up by default, because most of the neurologic disease will have a medical or a systemic comorbidity, whether directly or secondary to the neurologic involvement, they will tend to be followed by multiple specialties. And being followed by multiple specialties creates sort of fragmentation of care. So the neurologist will look at the seizures, the cardiologist will look at the heart function, the gastroenterologist will look at the hepatic involvement, but then we need someone to keep an eye on the patient as a whole and look at the patient as one entity. So that takes me back to the pediatrician or the family physician, the primary care being the medical home hub for the patient. It's the specialist role to evaluate the nitty-gritty details of each system involved, but it takes us back to the integral, a very important role. Actually, it's the most important role of a physician following a child with complex care is the primary care, because it's the physician who will focus on the day-to-day life, on the whole medical aspect of the child, and will provide the continuous and longitudinal care. So, what is the emotional and practical impact of a neurologic diagnosis? So neurology in general is like a taboo or a black box that even for physicians other than neurologists, it remains this mysterious diagnosis. So imagine the family. So we meet them in the first time. We say, your child has a diagnosis of X, let it be a leukodystrophy. And then we tell them that, or a case of near drowning with severe anoxic or moderate anoxic brain injury. So we say the child will be at the spectrum of moderate to severe involvement. We cannot tell at this time. The child is at risk of developing further symptoms as they grow older. So there is this emotional and shock and grief, emotional burden and shock and grief that the family is faced with, because they just don't understand. There's a lot of information that I'm giving. There's a lot of uncertainty. So and we refer them to the other specialists to rule out either systemic involvement or to prevent sequelae or prevent complications. And then they're left with multiple specialists, and each one is giving them a different opinion. And that creates a lot of burden. They feel that it's their job to transmit the message of each specialist to the following doctor. They're left with multiple appointments, there's twice a week physiotherapy, there is a neurologist appointment, a pediatrician appointment. So they feel as if they have loss of control over the situation. And that will translate into social and financial strain and difficulties. The family will tend to miss, the parents might miss work, or the kids will miss school because the child keeps getting admitted to the hospital. So it's important to understand the psychosocial aspect of a neurologic diagnosis. It is recommended that from a primary care standpoint, if you're the physician following the patient, to have the family come back to clarify what they learned so far, what did they understand so far. Normalize grief and denial. It is normal that they will feel angry, they will feel mad and sad about the diagnosis. Correct misconception early. We all have been in that place where you discuss with the family certain prognosis or a certain aspect of a disease, and then they come the next visit and you feel that they did not understand much about, or they did not grasp much. And it is a well-known fact that they will only retain around 20% of what was told to them. So correct misconception gently. Avoid toxic positivity. So validate their concerns, validate their fear, and ask them what is the one thing that will make a difference for them in their life right now. Language matters. So we have to try to use a very objective language with the family. So instead of using suffer from and victim from, which is a very emotional language, we should use a person-centered language. So he has a diagnosis of, or uses wheelchair for mobility instead of wheelchair-bound or cannot walk. And use yet to preserve hope when possible. A scenario that will support this is a child with CP that they're learning to walk. They started to walk with the walker, let's say, and the family say, oh, he's not walking. But you have to say not walking yet, because this will reinforce the hope. I remember one of my mentors early said, this family is the family that will take the child to all their appointments. They will take them to several interventions. So it's important to keep a little bit of window of hope when possible, because this will reinforce them to go from day to day and invest in this child. In older children, ask about what's the child like to do, what makes them happy, how's the interaction with the family, how is school, what activity does the child like? Because this shift from the disease-focused into a child-focused approach. So another part is the family. So again, being a pediatrician, being a pediatric neurologist, a family care physician, you deal with the whole family, not just the child alone. So ask about the siblings. A glass child syndrome or a glass child is a well-defined entity. A sibling of a child who has a long-term illness will be sort of a glass child, will be over-competitive, class A student, all to become invisible from and not create much burden to the family. So ask about how the siblings are doing. Ask about sleep. So the family will usually tell you the one thing that will make me feel good is having my child sleep at night. They know that the child will not improve, let's say, in a sense of after a period of regression. They know that the child will not get better, but what matters with them is sleep, because if the child sleep, they will sleep as well. Recognize caregiver distress. So a family who's always coming for all their appointments, who's always attending all their physiotherapy sessions, occupational therapy sessions, suddenly is not showing up for appointments, that's not losing care of the system. That's not them being not caring about the child. It's more of them being burned out, losing hope, losing faith in the system. Parents sometimes will shy away from going out in public with the kids or attending family gathering because they feel that they should not expose the child to germs. They should not take the child because he looks abnormal. A lot of the families, even with simple epilepsy, will tell you that they will not sleep at night because they will go and check on their child when they're asleep because they want to make sure that the child is still alive and they did not have a seizure when they're asleep. So in that sense, sometimes I recommend putting a baby monitor. So they will hear if the child starts to make sounds of a seizure, they will hear it, and that will give them some sort of control over the disease, because the goal is giving them empowerment, giving them authority over the care of the child.
5 minutes.
In this time and age, Dr. ChatGPT and Dr. Google is as equally as important as in the eyes of the family. So it's important to first acknowledge that they are actually trying to learn more about the disease and understand the situation, but in the same time direct them to reliable peer-supported resources, local support group for disorders if available, and use strength-based language. Always focus on the functional goals. What is the one thing that makes a difference in your life if we can obtain it? What do you think the future will look like? And this is all very important in the care of the child. Being the primary care physician, The family will appreciate it if you are the central communication, the gatekeeper of the the backbone of the medical system or the medical care of the child. Instead of the family feeling that they are the one who should report what the cardiologist said or what the physiotherapy said or any recommendation, assure them that you are the one taking care of the centralizing the communication. Be proactive in providing letters or support or school adjustment. Kids with neuromuscular conditions might not be able to go to their class if it's in the second floor. So proactively provide documentation that might help them to be in a lower class, let's say. Care for the whole child as a whole, not as a systemic involvement, systemic assessment as per the specialist. Routine pediatric care is very important in neurologic diagnosis, particularly because it's long-term illness, sleep, nutrition and feeding, bone health, mental health, mobility and orthopedic care, scoliosis, nutrition and growth. All of these are important aspects. If the child is presenting with severe change or a new onset change from baseline, always make sure that there is no hidden complaint that we cannot pick it up because the child cannot explain themselves. So oftentimes constipation is underlooked. Pain, sometimes it could be just a simple ear infection or a UTI, things that if you do not test for it, you will not pick it up. So a clear change from baseline does not necessarily mean a progression of the disease. What happens when medical care and family goal diverge? So we are not all on the same page. That's usually, first we have to understand why that happened. So again, fragmentation of care, that's a very integral role, very integral aspect, especially driven goals. So each one will give the recommendation. So the family feel again, maybe we are not all on the same page or between physicians themselves. Therapeutic burden, so what the family perceive as, what the physician perceive as a good response. So a simple example being we think, oh, the seizures are 100% controlled, it's good. But on the other hand, the child is left with very severe hypotonia or sleepy all the time or not interactive. Then we have to balance the goals of the family with the goals of the care and clearly establish them and identify them with the family. Quality of life versus biomarkers. Sometimes we stop chasing imaging and EEG findings and all of that and just focus on the well-being or the functional status of the patient, because again, all the goals should be driven by the functional status or what is an identified goals between the physician and the family. One of the very sensitive topics that might be discussed is goals of care. And there's oftentimes a huge misalignment, I would say, at what is the best timing to diagnose, to support limitation of goals of care.
2 minutes.
And that's mainly because there is different clinical perspective. So again, as a neurologist, I see the child in the beginning, they're still hovering around, maybe they just regressed, but they're stable. We don't know which way they will behave. I usually counsel the families that third will regress, third will be stable, and third will slowly improve maybe, but there will not be a significant improvement. So which way the child is, we do not know. A similar issue would be with early after mild to moderate HIE. You don't know how good the child will do, and they will need more time to clarify the prognosis and clarify how good would the child be. So again, early discussion of comfort care is not advised. Family perception of premature diagnosis. I remember this one scenario where the family it was a 6-month-old baby. They were hypotonic, but the child was very attentive and present. And at around 6 months, we had the diagnosis of a congenital muscular dystrophy. And the child coincidentally happened to have an aspiration pneumonia required ICU admission. So the ICU physician opinion then was, we should not go for invasive measures because the child has a terminal illness and they will not do well if we put the tube in. But again, the family perception of premature discussion, they just had the diagnosis. They haven't even had time to process the diagnosis. Coordinate communication needed for consistent family-centered care. Always try to have the discussion with multiple physicians involved. What is the opinion of each one, and how can we reach what is in the best outcome for the patient? And again, sometimes what we perceive as poor baseline is actually a good baseline for the family. So if the child is able to roll, able to interact, able to hold things and play with the family, but they have a progressive diagnosis, at that point, what we perceive as a poor outcome is actually a very good baseline for the family. So that is why sometimes expectations might differ from different specialties. So as a primary healthcare physician, it's important to define the family-centered goals, translate medical plans into day-to-day life, and improve the functionality of the family and the patient, and ensure that care remains appropriate and meaningful to the family. So in summary, be the anchor, be the backbone of the medical care of the patient, validate the concerns, and always ask about the child as a child and not as a disease entity alone. Thank you.
Thank you so much, Dr. Ghalia. Dr. Ghalia will present also the satellite symposium. I need to disclose we're not directly relatives. That's not the reason I'm giving her 2 talks. So please, she will be presenting a talk on introduction to the CDKL5 deficiency disorder. Looking forward to it. Thank you.
Yeah, I apologize. I'm doing the second talk as well. So I'll be talking in the next 10 or 15 minutes about ganaxolone and CDKL5 deficiency disorder. This is the late symposium sponsored by iMedica. We'll review the clinical and genetic background of CDKL5 deficiency disorder, discuss the pharmacological mechanism of ganaxolone as a GABAergic inhibitor, evaluate the clinical trial of use of ganaxolone and CDKL5. So developmental and epileptic encephalopathies are severe disorders in which epilepsy contribute to progressive developmental impairment beyond the underlying diagnosis or the underlying cause. It has an incidence of around 1 in 2 to 3,000 live births and account for around 30% of epilepsies with onset in infancy. Genetic etiology is identified with modern genetic testing in around 50% of the patient, allowing for better precision medicine and gene-targeted treatment. And CDKL5 is one of these genes that has a commonly recently identified target for emerging therapy with ganaxolone. So in a nutshell, it's caused by a pathogenic variant within the cyclin-dependent kinase, CDK5. It's located in the X chromosome. The diagnosis is usually based on a constellation of symptoms being early refractory onset epilepsy with normal MRI and a confirmatory genetic testing. The CDKL5 gene is located, it has 2 parts. It has a catalytic domain responsible for the enzymatic activity. It has a regulatory domain responsible for the protein function. Mutations within the protein function or the C-terminal is more pathogenic, is more common, while mutation within the enzymatic activity part or the catalytic domain is more pathogenic. Usually patients all of them will have a triad of hypotonia, global developmental delay, and early onset epilepsy that is refractory to treatment. The majority of them will have abnormal speech, sleep irregularity, feeding difficulties, cortical visual impairment, and recurrent respiratory infections. Seizures are a hallmark of this disorder, and they present early in life. Around 90% will have their first seizure by 3 months, and the majority will have had their first seizure by 6 months. Seizure semiology is variable. It includes epileptic spasms, tonic seizures, myoclonus, and generalized tonic-clonic seizures. Seizures were daily in most of the patients, or around 80% of the patient had daily seizures, and they were usually refractory to treatment. In terms of the medication that were used in treatment of CDKL5 prior to the era of ganaxolone, most of the medication were poorly effective, ranging from 5 to 36% of response, and that's a reduction of seizure frequency of more than 50% in 3 months. The medication that showed some effect or better effect compared to others were the valproic acid, vigabatrin, and Lamictal. The hospitalization were mainly due to seizure-related admissions, with a median of around 3 weeks of admission. Other admission-related disorders were chest infections and acute illness. So what is ganaxolone? Ganaxolone is a neuroactive steroid. It's a synthetic analog of alloproganolone, which is a GABA-A modulator. So it enhances the GABA inhibitory effect. It works in both the presynaptic and extrasynaptic terminals on the GABA-A receptors to maximize the inhibitory effect. It has a half-life, an initial half-life of around 7 to 10 hours and a terminal half-life of around 34 hours. It's metabolized by the liver with a minimal CYP 3A and 3/4 contribution, requiring adjustment of the dose if patient is taking any enzyme inducers. In terms of dosage, it's approved for kids above 2 years of age and seizures associated with CDKL5 disorder. Starting dose is 6 milligram per kilo and up to 63 milligram per kilo per day. And usually the titration phase is 3 to 7 days. Dose adjustment might be needed with enzyme inducers, and the major side effects were sedation. And the last part of the study will look at the Marigold study, which was a global phase 3 trial in ganaxolone. In terms of the characteristic of the study, it was a double-blinded placebo-controlled clinical trial. The primary endpoint was percentage of seizure reduction at 28, motor seizure reduction at 28 days. So motor seizures were identified as generalized tonic-clonic, focal clonic to generalized tonic-clonic, to bilateral tonic-clonic, and atonic seizures. The key secondary endpoints were percentage of decrease in seizures of more than 50%, and the clinical global impression of improvement for the clinician and the families. They included patients less than 21 years and above 2 years of age, with confirmed diagnosis having more than 16 seizures per day and are on more than 4 anti-seizure medication with failure of at least 2 medication. It was the seizure history was reviewed before the initiation of treatment. The patients were put on placebo and ganaxolone with the titration phase for around 13 weeks, and then it was an open label study. In terms of the basic characteristics, they were similar between the two groups. In terms of the primary endpoint of percentage of seizure reduction in major motor seizures, the ganaxolone group showed a significant improvement with around 30.7% seizure reduction. The key secondary endpoints of 50% responder rate at 3 months were also more within the ganaxolone group. The clinical global impression of improvement caregiver. So the caregiver were given a questionnaire rating their improvement. So at least minimal to moderate improvement were achieved as per the family in 63% of the ganaxolone group compared to 44% in the placebo. The physician impression of improvement as well was around 50% of the group compared to 40% in the placebo. The efficacy by seizure type, again, ganaxolone showed a major difference in terms of the motor seizures, in terms of the response. The treatment emergent adverse events were mainly sedation. However, 2 patients discontinued the treatment, one because the seizure did not show significant difference, and the other was to sedation, and there was no serious side effects or any treatment emergent side effect leading to death. The study was extended for a 2-year follow-up. Again, showed similar findings with 25 to 42% in persistent reduction and up to 44 to 52% at 2 years of follow-up. And it showed similar baseline safety findings. So in summary, CDKL5 deficiency disorder is a rare developmental epileptic encephalopathy with early onset treatment refractory seizures. Ganaxolone has been approved recently for CDKL5 disorder, which has a GABA-A receptor inhibitory effect and tolerable side effect of the sedation, mainly when looked at among the study population. And thank you.
Thank you so much, Dr. Ghalia. Very engaging and up-to-date talk. So we'll open the floor for any questions that you have for all the previous talks, whether it was for Dr. Ahmed or Dr. Ghalia. So if you have any question, please feel free. Dr. Sama.
Thanks to the speakers for your excellent talks. A question, Dr. Ahmed. If I'm a general practitioner or a general pediatric and I encounter a patient in whom I think he could have autism spectrum disorder early signs, what are the initial signs I should think of before referring to a neurologist or a psychiatrist?
يعطيك العافية دكتور سامة. So I mean the first thing you have to think about one is if the patient is not if he has a poor eye contact or not pointing at age of 1, not having a single word by age of 18 months, not recognizing or responding to his name by age of 1 again, or 2-word sentences by age of 2, I think you should refer the patient to a specialist. Other features, regression. So if the patient is used to speak but he starts to regress, definitely you have to refer the patient to a specialist. I'm encouraging not to adopt or wait and see approach. So if you are concerned, if the parents are concerned, always trust the parents and refer the patient to a specialist.
I received a couple of questions from the online attendees, and this is a reminder if you're attending on Zoom or YouTube. Luckily, you have a Gen Z moderator, so we can multitask. So the questions are directed to Dr. Ahmed from Mohammed Al-Ataibi. Does every patient with autism require genetic testing?
Thanks, Mohammed. So not every single patient with autism requiring genetic testing. However, recently in the European Neurological Academy in 2023, they're encouraging to do genetic testing for autistic patients. Now, if you decided to do genetic testing, or before that, if the patient has a positive family history, the patient has dysmorphic features, neurocutaneous lesions, that's a different story. Then you have to do genetic testing. But we're talking about pure isolated autistic features. If you are planning to do genetic testing, then the recommendation to start with chromosomal microarray. If that is negative, you have the options either to do the WIS, whole exome sequence, or just to go to a whole genome sequence, which is now it's quite equivalent in terms of the pricing. So recommendation is to do chromosomal microarray, then WIS. And I would say if the patient can afford whole genome, just do a whole genome, start with the chromosomal microarray, then move to a whole genome sequence. Having said that, keep in your mind, doing genetic testing will open closed doors. So you should have a geneticist or genetic counselor with you, because you might find a couple of things that actually you're not expecting, and then you have to discuss this in details with the family, which might affect their planning and family counseling.
Thank you. And there is a follow-up question from the same attendant. When do MRI in autistic and ADHD children, when to do MRI in autistic and ADHD? So
again, MRI is not a routine test for any patient with ASD and ADHD, but if the patient has regression, especially rapid speech regression, patient has dysmorphic features, microcephaly, focal neurological signs on exam, neurocutaneous lesions, positive family history, or you are in concern or you're not in doubt, you can do the MRI, but again, be reminded, please, and MRI, especially in autistic children, requires sedation. So it's not a primarily completely safe procedure. So I'm not encouraging to do MRI for every single patient, but if you have one of those red flags, you can justify doing an MRI brain.
Great. Any further questions? Take one.
I hope it's Dr. Jan is for Ghali, I hope. Okay, good.
Thank you very much, Dr. Ghali. It's such a brilliant presentation supporting families. And I think this is one of the things that we as doctors are really not good at. And this is not well taught in medical school. And it's something we learn as we progress through our encounters with patients, how to communicate with these families, how to support them, what to say, what not to say. How much burden do you put on these families as they go along? It's not just something you wanna just download on these families from up front. It will just break their back, you know? And so I just wanted to congratulate you for this presentation. And I think this is one of the things that makes a difference between a good, successful neurologist and maybe very brilliant neurologist, but not as good as in patient care and looking after these families.
There is one last question here in the back. No, in the back. The next one, Dr. Arish.
Assalamu alaikum. Thank you, Dr. Ahmed. About the earliest manifestation of the autism in baby in one infant 6 months, what is the earliest manifestation as general pediatrician diagnose this baby go to autism in 6 months?
So 6 months is a tricky age because, I mean, yes, people, they do say that you might see, in retrospective, you might actually pick up some signs at age of 6 months, but prospectively, I think it's a bit difficult to say at 6 months of age, this patient might develop autism, but I might say if the patient is not having good eye contact by age of 6 months, I mean, you don't have to jump and refer, but keep monitoring this patient. So not having good eye contact by age of 6, because babies, by age of 6 months, they should be very attracted to faces. So if he's not attracted to face or eyes, that's one thing. If he's not recognizing his name by age of 8 months, I think that's another red flag you have to keep in your mind.
What is the early treatment as this patient autism? Is it psychiatric treatment or neurological treatment?
So neither actually. It's a behavioral treatment. It's not psychiatric or neurological. So the thing is, one thing before you jump to treatment, make sure the patient does not have hearing impairment. So check the hearing with the audiology. If that's cleared out, then refer to an early intervention. So the treatment actually is done by our colleagues in psychology, so like the behavioral specialist, I mean. So they do and start involving the parents and the families with the patients. The neurological treatment or psychiatric treatment is mainly for the coexisting symptoms. Seizure, for example, we treat seizure, and anxiety, we treat an anxiety, irritability, we treat an irritability. So it depends on the other symptoms associated with autism.
We'll take one quick question from Dr. Arish.
Assalamu alaikum. Question to Dr. Ghali. I have two practical questions. I promise they're not going to be long. The first question about the idea of complex care. We have trained together in the same hospital and we have seen complex care, and I think complex care is just amazing at the primary care settings. So what can pediatrics care or family medicine care? Is this available here? Because I feel it's the most, it supports families, like outstanding support to the family. The first question. And the second question is about goals of care. When you discuss goals of care, since your patients are quite, I want to say, almost terminal, or they will have a terminal diagnosis, how do you approach your patient cases with DNR? Since DNR require two consultants, per my understanding, to sign a DNR order, how do you discuss the case with a colleague, or how do you go over this from a practical situation again? I'll start with the second question. So usually I shy away from discussing goals of care with the family from a first meeting. Even if they have a confirmed diagnosis, I still think you need time to establish trust and rapport with the family. My population will be followed by me and the metabolist, so we'll sit together and discuss the case. And usually before even I approach the family, let's say in the first visit, I will disclose that we're looking at a wide, let's say, or a variable prognostic trajectory. I mean, with subtle differences, I would use the third will stabilize, third will regress, and third will slowly improve. They will always remain delayed, and they will always remain at risk. The things that will reinforce the trajectory would be having recurrent chest infections, recurrent ICU admissions. So I know once the child starts to have multiple admissions, start to have recurrent ICU admissions, that this is roughly around the time because the child will start to regress. Another issue within that context I find when discussing with pediatrics is that the child will regress when they're ill, but you have to give them time to recover from the acute illness. So what we were told that the child has regressed and they're not improving, you actually have to give them a few weeks at least to see if they will pick up to where they were for a baseline point of view. So yes, either I'll have the discussion with my colleagues in neurology or the pediatrician or the pediatrician, let's say National Guard, or the metabolist who's following the patient. So just to have sort of a collective agreement. It's a major decision to be discussed with the family, and it's a very sensitive topic, irrespective of how many times you've discussed it with the family. Each family is different. So I would be very cautious before approaching the complex care, the limitation of goals of care as much as possible. Yeah, just to sort of give them the benefit of the doubt. And for complex care, so we have in National Guard complex care. It's not complex care neurology, it's complex care from a pediatric standpoint, but they can help with and we have palliative care as well. So they can help in terms of alleviating pain, supporting the child through the different crises that they might go through. But having a pediatrician identified for the family, taking care of the medical aspect, optimizing the general health, I think, is as important as complex care in that setting, because you want to prevent the sequelae, you want to prevent the comorbidities before they arise and have more of a proactive rather than a reactive role.
Thank you. Okay, so now we will move on to another debate question. So again, if you can take out your phones. We'll ask you a few interactive questions in the domain of rare diseases. So, how many red flags are enough to suspect a rare neurological disease? Again, these things, especially in this segment, they didn't have a clear guideline or cutoff, so we want to see your perception. Multi-system featuring, we close the survey. Okay, slightly, 3 or more multi-system features, okay? So you need to make sure. Okay, proceed to the next question. For the next question, would you order genetic testing if you had the privilege before specialist referral? Yes, no? Yes, Dr. Reese said yes because she's at King Faisal, she has the privilege. Show the answer. No, most of you would refer first. Fair enough. Okay, an overwhelming majority. Next question. Is AI currently reliable enough to assist rare disease diagnosis in primary care? What do you think? By knowing those who taught me in medical school, I think I know who selected overhyped. I think helpful but not diagnostic. The majority are answering, but split among the other. Okay, fair enough. So we'll start now the rare disease session. And before I start, I would want to say that it is a big pleasure to share the podium and the session with Prof. Jan. They told me that 2 youngest speakers would present in the rare disease, so it's luckily you and I. Prof. Muhammad Jan is a pediatric professor emeritus and consultant pediatric neurologist and clinical neurophysiology at King Abdulaziz University and the Saudi German Hospital. He specialized in evaluating, diagnosing, and treating all types of children neurological disorders, including epilepsy, neurological convulsions, febrile seizures, nervous delay, mental disability, motor disability, cerebral palsy, muscle weakness, headache, migraine, autism, language delay, and developmental disturbances. In addition to the evaluation of EEGs, clinical neurophysiology, laboratory test, Prof. Jan would guide us in a talk entitled, When Should GB Suspect a Rare Neurological Disease? Welcome, Prof. Jan.
Bismillah ar-Rahman ar-Rahim. Thank you very much. Thank you, Anas. Thank you, Dr. Ahmed, Dr. Osama, Dr. Ashraf, and all attendees. I think pediatric neurology is full of rare and wonderful kind of diagnoses and disorders, and many times I think in almost every clinic we have a puzzling kind of clinical situation or a clinical diagnosis or management issue. There are many genetic, metabolic, degenerative, progressive disorders that we see, and evaluation of these children really requires knowledge, accurate assessment, and formulation of differential diagnoses. Such initial assessment really will further direct how we will proceed and how will we investigate. However, a specific diagnosis is really needed in order to properly manage the patient and counsel the families. Rare diseases are often considered when the prevalence is less than 1 in 2,000. There are many rare disorders. The last count was maybe more than 7,000 rare disorders with this kind of prevalence. So, but collectively, although each one is very rare, collectively they may affect up to 1 in 20 people. 80% of these rare disorders are genetic, 70% occur in childhood, and most common really are neurological. So when should general practitioners suspect a rare neurological disease? Your initial questions, good, that guided us initially, but there are developmental red flags because development is a big chunk of what we see in pediatric neurology. Also unresponsive seizures. Seizures are other very common encounter. Unusual neurological signs. Recurrent unexplained events or unexplained or unusual clinical course of a given problem, multi-system involvement, also when there are unusual family history and recurrence and genetics, of course. So developmental red flags, just to stress to our general people, the neurologists will know this, but we generally in CNS insult, we have static insult, like for example, cerebral palsy. The insult is fixed more or less, but the brain will develop, will myelinate, will maturate, will connect. So patients with, هنا في pointer في ده اللي فوق ولا اللي تحت؟ ما بقفله يعني. ده ممتاز. شكرا. ممتاز. لا, this is very confusing. So patients with CP, normally they will improve with time. They should have some improvement. There is mild, moderate, severe. The progressive will be easier to pick. So metabolic, genetic, some progressive disorders, they tend to get worse. However, note that if there is a severe static insult, severe devastating CNS problem, the patient may have the so-called developmental arrest. So the child will not really gain any. On the other hand, when you see such developmental arrest, still consider an early progressive problem. So an early onset metabolic disease may look like a severe cerebral palsy. So when we look at regression, so we see child with losing developmental milestones, we think of metabolic, degenerative, but also keep in mind, you heard a little bit this morning about neurobehavioral syndromes. These children, they can regress socially and developmentally. Psychiatric disorders are rare, but they are seen in children, neglect, depression. Also, sensory insults. So a child with progressive hearing loss may become ataxic, may lose skills, and also intractable epilepsy can result in regression. Because we are talking about rare things, I'll just give you some examples of the rare disorders that I have encountered early on. Initially, back in King Faisal, we collected a number of children who were diagnosed as CP, and a couple of them actually were wheelchair bound. And actually what they had with genetic testing is the so-called Sigawa disease or DOPA responsive dystonia. And when L-DOPA was started in these children, they have significant improvement. Unresponsive seizures, of course, common is common. So when you see seizures that are not responsive, you will think about compliance. These are the common things, the dose, maybe the diagnosis. So I ask parents to get videos. You double check your diagnosis, double check your seizure classification, your medication, maybe you're not using the right medication. As well, look at the etiology, because we are dealing with rare disorders. When you see seizures that are not responsive to your usual anti-seizure medications, think of these disorders: neuronal ceroid lipofuscinosis, mitochondrial disease, progressive myoclonic epilepsy, genetic problems. You heard about epileptic encephalopathies. Also, some of the rare things that we see in pediatric neurology, maybe you as general practitioner, you may not recognize. There are some kind of bad epilepsy syndromes. You may or may not know them, but they present with really difficult to control seizures, like early myoclonic encephalopathy, Dravet, Dosset syndrome, infantile spasms, Lennox-Gastaut syndrome. So maybe the patient has some kind of epilepsy syndrome. And getting the right diagnosis, you may use targeted therapy. So some of these patients may respond to certain medications earlier, for example, vigabatrin or steroids. In addition, just the last point about metabolic, about epilepsy, there is the so-called treatable inherited metabolic epilepsies, and the list is really getting longer. In the past, we used to know mainly B6 dependency, which present in the neonatal period, but now we know that there is a number of these disorders, and these disorders are potentially treatable. And if you use all the medications, all the anti-seizure medications, the patient really will not respond unless you give or replace the deficient cofactor or vitamin. الفيديو هيشتغل؟ يعني مثلا this is an example of a child who was diagnosed with epilepsy, just for interest, one of the rare things. And he actually came to me from Taif, not from here. اللي تحت تحت في start في النص، نص الصورة على اليسار. أيه. Can I move it here أنا؟ لا. Oh, maybe I can. Anyway, the child was on 3 anti-epileptic medications, and he was having these episodes sometimes daily. He will stand up, his legs will cross, and he will look really distressed. طيب ممكن نعدي عشان الوقت، مين مشكلة إذا ها؟ Okay. Anybody knows the diagnosis? ها قبل ما نشوف الفيديو. The child had EEGs, had MRIs, and EEG MRI was normal. So what this child is actually, what he had is, he had chronic constipation. He did not have epilepsy, and what he was having is something people call stool withholding phenomenon. So he'll have a kind of a bowel motion, and because of the pain, he will have this posture. نفس المشكلة أتوقع ولا يمشي الحال؟ These are two different videos of a relatively uncommon problem, again diagnosed and treated with no benefit. Okay. This is a patient of Dr. Dina Bahadir, actually, in Mecca. This child will respond really excessively to tactile stimulation. Next one. This is an infant where with sound or with touch, he will develop this kind of tonic spasms. They were treated with anti-seizure medications with no benefit. And what these two children had, infants, is really... What's the diagnosis here? Yeah, hyperexplexia. So hyperexplexia is kind of rare, it's familial, startle, and can be evoked by auditory or sensory stimuli. Babies, they can present with hypertonia. And hypertonia is really uncommon in the neonatal period. You just don't see babies who are hypertonic. So this is one of the rare differential diagnoses of hypertonia in the neonatal period. These are the genetic associations with this disorder. One of the parents may have it, so we have the no-stab test, and children may respond to benzodiazepines, but treatment is not really a must. But careful examination is needed because Tay-Sachs disease can present with auditory myoclonus. This child came to me, and the mother insisted that the child, actually the seizure is when she changes the diaper. And I, of course, did not really take that seriously. But I told her, well, videotape it, show me. So here she was changing the diaper of the baby. And indeed, the child had a focal seizure, actually, clearly, with the diaper change. So, what's the diagnosis? It's actually not the diaper change. It's actually the warm wipes. So when she changes the diaper, she applies warm wipes to clean the area. And this child actually had, sorry, I have to go back. This child had reflex seizures because of due to the change in the temperature of the skin, and actually testing revealed that this child had Dravet syndrome. This is well known in certain genetic epilepsies in India, for example, where children shower outside, so with the shower they develop seizures. Rare, extremely rare. I think this was your first paper, Ahmed. This is a child with West syndrome, and West syndrome is not uncommon. So you have infantile spasms, you have hypsarrhythmia, but here MRI sometimes diagnose rare things. So this is a girl. So what's the diagnosis? So the MRI reveals this, what looks like chandelier in the so-called colpocephaly. There is agents of the corpus callosum and dilated posterior. So this is Aicardi syndrome. Child will have retinal lacunae and occurs in girls, so very rare. The third category of things that make a generalist suspect rare disease is unusual neurological signs. These are generally easy to pick because there is an abnormal sign, so you know that there is something wrong in terms of head size, cranial nerves, neurological examination. However, be aware that some neurodegenerative and metabolic diseases, the neurological examination can be completely normal. So lack of signs does not mean that there are examples here mentioned in the skin, in the hair, Menkes disease, facial dysmorphism in Zellweger, hepatosplenomegaly, storage diseases, cardiac, progressive renal failure. This is less encephaly, less cortex. So you have smooth cortex or figure of 8, different grades, and it's been associated with the so-called Miller-Dicker syndrome. So what's the diagnosis here? So this is tuberous sclerosis. Okay. So a child with epilepsy have the so-called epiloia or adenoma sebaceum. It's actually angiofibromas and ash leaf spots. And the one in the back here is Chagrine patch, TS, tuberous sclerosis. This is an unusual, زي كأنها كده قهوة بالحليب صح. So this is what? Rare معلش, incontinentia pigmenti. This is a neurocutaneous syndrome, okay? This child actually had irritability, seizures in the neonatal period, and skin rash. And this is biotinidase deficiency. And this is potentially treatable. So if you give anti-seizure medications, the patient will not respond. Biotinidase deficiency.
3 minutes.
Huh?
3 minutes. Here.
3 minutes, sorry. You have to be more aggressive, Yanis.
صح اني تخرجت بس.
During my training, we collected patients with the so-called Nova Scotia Niemann-Pick disease, type D. And what is peculiar in these patients is they have supranuclear gaze palsy. So when they come, they cannot look up. So, and this is very peculiar sign for this disorder. So if they want to look up, they move their head up. However, on testing, the eye is able to move, so it's not paralyzed. It's supranuclear. Ataxia telangiectasia. Sometimes we diagnose these ataxic children as they come into the clinic. The eye, there are many disorders. They have really specific clues for the diagnosis from the eye: cherry red spot, corneal clouding, in mucopolysaccharidosis, and so on. This is also a rare patient that I have encountered, presenting with facial, what looks like Bell's palsy, but the child was not improving. And actually, this child died 3 months after the onset of the Bell's palsy because nobody really examined the ear. So this is one of the important things. Any child with facial weakness, you have to examine the ear, and this was a case that was missed in Canada. The child had a rare rhabdomyosarcoma. More common is really otitis with effusion, and it can be associated with recurrent unexplained events. Again, can point toward a milder or undiagnosed metabolic, genetic, progressive disease with infection, fever, illness, fasting, a high protein meal in certain amino acid disorders, or exercise. I'll skip that. So assessment, it's important really to have a comprehensive, detailed history exam, be aware of diagnostic labels if the patient is not doing well. So misdiagnosis, formulate differential diagnosis, further lab testing as needed. You heard about genetic testing, and some people, some generalists, they would say, well, why would we do it? Many of these disorders, they have no treatment, so why do we bother? I think having a specific diagnosis is very important because we now know that many of these diseases, there is actually a specific treatment. You need to assess and counsel the families about the clinical course, the outcome, what to expect, the prognosis, genetic counseling, counseling them about recurrence risk for future pregnancies and prevention. So establishing a genetic diagnosis is really crucial. So the role of the GP is really many times not really to come up with a specific diagnosis, but to recognize these red flags that I have summarized. Beware when things do not fit, common patterns, and really early referral. Thank you very much.
Thank you so much, Prof. Jan, for the extremely informative talk and for guiding GPs on how to suspect a rare neurological disease. So, without further ado, I would like to introduce myself. I will be the next speaker. My name is Anas. I'm a general practitioner myself, currently practicing at the King Faisal Specialist Hospital here in Jeddah. Alhamdulillah, I managed to publish over 50 research articles in pediatric neurology, currently pursuing my fellowship in research at the London Royal Hospital. And I will be talking about AI in rare neurological diseases, the current reality and the future direction. So this will be the outline of my talk. Why does rare disease in general matters? As Prof. Jan said, so far collectively they encompass over 7,000 conditions reported worldwide. Here in Saudi Arabia, it is estimated that we have 370,000 persons affected with or living with a rare disease. Usually the prevalence in terms of age groups, they present 50 to 70% in childhood, with around 40% of them having a nervous system involvement. Usually those conditions have a diagnostic odyssey or a diagnostic delay of often 5 to 7 years. What are the clinical problems for general practitioners? The fact that most of the early symptoms are non-specific. They are developmental delays, seizure, hypotonia, regression, as the previous speakers demonstrated. And many children see multiple physicians in reality before reaching a diagnosis. So what is artificial intelligence? AI is the simulation of human intelligence in a machine-programmed way to think and learn like human. AI systems are capable of performing tasks that includes pattern recognition, machine learning, and problem solving, and we will see how these tasks could aid in medicine in general and specifically in rare diseases. So what do we mean by AI in medicine? The term machine learning is a subset of AI where algorithms learn from data to improve performance on a specific task, where deep learning is a specialized machine learning technique using multi-layer neural networks to process and model complex data patterns. And we have a term called computer vision, which is an approach that enables the computer to see and interpret visual data such as images, videos by mimicking the human visual perception. And lastly, we have a term called the natural language processing, which is a branch that enables computer to understand, interpret, and generate like a human language. And this is the interconnection between those terms. So you can see the AI is the big compass of that, where each have its own specialized approach. Quick fact check, globally we have 4.5 billion, not million, billion people lacking access to essential healthcare services, and healthcare workers are expected to have a shortage of up to 11 million by the year 2030, that is globally. And AI technology are already helping doctors to spot fractures. It's already being used. So I remember doctors saying AI is not the future, it's actually our present today. It can already spot fractures in orthopedic and other specialties. It could triage patients in ER and detect early signs of diseases, whether it was internal medicine, pediatric neurology, or etc. Yet healthcare is labeled below average in its adaptation to AI compared to other industries, and this is according to the World Economic Forum. So we still have a long way to adopt AI in medicine. Even if you are using it and you think we're overusing it, we're still below average. So where do we use it currently in medicine? For the brain, there is a lot of software, including a new AI software that is twice as accurate as human in examining brain scans for stroke patients, which was a tool developed in the UK. For bone tools, there is an AI tool that can spot bone fracture even more accurately than human. And there is the use of AI in ambulances. For example, there was a tool that was developed, and it showed that 80% of cases that the AI could correctly predict the patient that needed to be transferred to a hospital or not. And there are diagnostic models where there is also a new machine learning model that can detect up to 1,000 disease. And in that study, they saw that the model discovered the condition even before the patient reported any symptoms. This is one of them. This is the fracture study that showed that this model now reads X-ray in urgent care even with a more accuracy and sensitivity than human. So in pediatric neurology, there is another example where for a UK study that found that there is an AI tool that can successfully detect 60% of epilepsy brain lesion that was already missed by radiologists. And there are plenty of tools that are coming into practice, specifically in pediatric neurology. For example, this is the MILT study, the study that saw the brain lesion that was missed by the radiologist. In that interesting study, it was a tool called SCORE AI, which we are replicating here in Saudi, that fully interpretate EEG, that could aid general practitioners to read EEG confidently without the need of a specialist. So where is AI already being used today for rare disease? This can be divided into 4 major clinical domains. 1 is morphology and genetics. 2 is neuroimaging, 3 is genomic and variant interpretation, and 4 is digital phenotyping. There are points beyond that, but these are the 4 major ones. So in this morphology and genetic syndrome, so children with rare neurogenetic disorder often have facial phenotypes. So these AI tools can analyze this facial pattern. So we spoke about pattern recognition. This is where it comes into handy. An example, these are existing tools, the Phase2 gene, Gestalt matcher, deep Gestalt. Their impact, they improve the genetic testing selection, shortens the time to diagnosis, the 5 to 7 years that we spoke about. These tools can help you shorten that. And the clinical use, they can support, as Dr. Ahmed showed us, a child of a Rett syndrome. These tools can help you detect these rare conditions. Also Angelman syndrome, Kabuki, Noonan syndrome, and others. So for a GP, if a child having dysmorphism, neurodevelopmental issue, if these tools can help him consider genetic referral earlier. For neuroimaging, it can analyze MRI of the brain structure abnormality, white matter disorder, and there are already tools that automatically detect polymicrogyria, or there is also another tool that classifies leukodystrophies, and they can be applied for leukodystrophy pattern recognition, cortical malformation detection, tumor classification. And this radiology support is helpful for the GPs, especially in subtle or rare image patterns. For genomic and variant interpretation, a lot of recommendations are coming out to use genetic testing, but in modern sequencing produces thousands of variants. AI can help identify which one is likely pathogenic in a faster way, not necessarily in a more accurate setting. An example of this, a tool called ExoMicer or Deep Variant, that could integrate phenotype data, genetic variant, and literature databases to tell you that, or to, in general, to increase the diagnostic yield in exome sequencing and to provide faster interpretation. For digital phenotyping, there are plenty of tools for eye movement, gait patterns, speech abnormalities, behavioral signals that could early detect certain conditions like Rett syndrome, or provide gait analysis for neuromuscular disorder and then classify it, and eye tracking biomarker, which is another project that we are starting to develop at King Abdulaziz University. So this is a case example. Let's say we had a child with developmental delay, epilepsy or seizure, mild dysmorphism. A traditional pathway would include a GP, pediatrician, consulting a neurologist, then ordering WIS, referring to a geneticist with an MRI of the brain, depending on when will this image come. And so all of this process, even in an ideal take In our daily use, we have the big four. Has anyone ever used one of them? All of us. So I asked myself before, which one is best for what? So ChatGPT was concluded that it is best for explaining complex medical concepts, defining research protocols, simplifying statistics, and assisting beginner researchers. The strength of it has a strong medical language capability, excellent logical reasoning, and helpful for refining ideas. The ethical limitation for it should not replace writing study results, generating data, or actual data analysis. When, for example, Gemini is good for integrating text and images, and analyzing multimodal data and any research that is related to public health. Why? Because the ecosystem of Google itself, it integrates a big proportion of data that could be valuable in public health setting. DeepSeek, which is my favorite tool, is good for deep logical analysis, handling technical data and complex computer research. This is best suitable for those with technical statistical background, where Perplexity is similar to a new tool called Open Evidence. It's good for rapid or quick source-based searching, summarizing recent scientific evidence, and verifying information with references. And Perplexity functions more like an intelligent researcher or librarian rather than just a writer. And there are other emerging tools. Has anyone ever heard of this superpower? It's just like 1 month old. It's a new tool. They claim it's very accurate. It is used by patients, not by clinicians, that they tailor their own medical record. They provide biomarkers, they provide tests. I'm not sure how accurate or good it is, but they claim they have high accuracy. And then it actually suggests for you the supplements and the medication that you should go and find, and the store that you should buy from. So which is the best in pediatric neurology? We actually did an objective assessment. It was Dr. Osama and I. This is a paper under consideration for publication. In general, it showed that DeepSeek is good. It has the least critical safety flags, while ChatGPT was the most hallucinative, the most fabricating, and we assessed different domains for the factual accuracy, safety, harm, readability, and tailoring, which one is the best for readability for the general public. And it's always important to note that clinical chatbot will guide healthcare decisions, and doctors must take informed and quick decisions. AI could speed up this process, but could provide unreliable or biased information. There was a study in the US that looked into standard large language models like ChatGPT, Cloud, Gemini, and they were unable to provide clinicians with sufficient evidence-based answer to their medical question. And it suggests, and the percentage was very low, it was like 2 to 10%. But it compared it to another tool called Chat Real World Data that increased the percentage up to 58%. So we have other tools beyond the traditional ones. And it's always important to note that doctors and patients have two different experiences. In controlled settings, there was a study that did a controlled setting and tested models like ChatGPT. It performed very well with giving complete clinical scenarios. It identified correct diagnosis in most cases. However, they tested it out on real users. The performance dropped significantly. In one study, chatbot user often underestimated the severity of their symptoms, and it performed no better than just a Google search. The overall accuracy to correct diagnosis and to choose a correct medical action was only 43%. So the common problems that a patient could include: providing complete clinical information, they ask close-ended or poorly framed question, and misinterpret or choose a wrong suggestion that the AI built. The current limitation and ethical concerns include data bias. AI model depends on the training data sets, so it can be underrepresenting certain ethnicities and groups, and we in particular here in the Middle East are affected, and I will show you a few examples. And we have the issue of privacy and data security. We said that there are tools that do facial recognition pattern, but is it ethical or legal to put the face of a child in that model, and where does it go to? And there is the issue of interoperability. There is a concept called the black box, which I will explain shortly. It will necessitate that the clinician must still interpret the result that this model shows. So it's like an assistant. It just tells you an answer and then you evaluate. And then we have the over-reliance risk. And I think this is an area of study that we see clinicians, students, and others, how much are they over-relying on AI models. So AI should support, not replace clinical reasoning. This is, I'm sorry for this example. This is an example. Have anyone seen this tweet? I've seen it, I remember. Do you know the Grok trend, telling Grok, remove that person, do that person? So this was an example. I remember I was scrolling in my X and then I saw this tweet and one asked, please remove the potential person that would be harmful to the society. And it just removed the woman that was wearing a Muslim attire. So no one taught him that, no one prompted him that, but it was built in his essence to be biased, reinforcing harmful ideas into minorities and certain ethnic groups. So this was a striking example that I remember seeing, and I could not move on, and it sparked a big debate. And there is the black box theory, which is AI would give you an answer. They tested it out, for example, in this image. They showed him a dog, but they showed him a dog, and he said that this is a wolf. And then they put a complete investigation asking, why did you conclude this is a wolf? And it ended up saying, I'm not sure, I just said that. And this is what the actual model said. So many times it will hallucinate, it will go into a black box, and this would be even more harmful in a medical context. It will give you an answer, and then after you do a complete investigation, it will just tell you, I'm not sure how I said that. And this would raise the point that AI will always hallucinate. OpenAI itself, the company that made ChatGPT, they published a paper. They proved that ChatGPT will always make things up. Not sometimes, not until the next update, always. And this was surprising even to me. This was proved by math. Even with the perfect training data set and unlimited computing power, AI models will still confidently tell you completely false things. This isn't an issue or a bug that they will solve. This is baked into their fundamental level. And their own number are brutal. Like the first AI, the first ChatGPT that came out, their hallucination was 16%. The third model, the newer one, was 33%. And the newest one, ChatGPT 4, was 48%. And for some reason, it kept increasing. So you could see that nearly half of the data could be fabricated. And the smarter model are actually getting worse in telling the truth. But they give you a more satisfying answer that pleases one's ego. So OpenAI proposed to fix it. How? By telling ChatGPT to say, I don't know and I'm not certain. So by applying the math, this is saying, I'm not confident enough to answer you, to 1 in every 3 of your answers. So imagine opening ChatGPT, and 1 every 3 times it will keep telling you, I'm not sure. This was very recent, in September 2025. A fun fact, AI started to develop feeling. Recently, the CEO of Cloud say, there is may or may not a gain of consciousness between our AI model, and we don't know how this started. And the first, do you know what's the first symptoms that the AI started to develop? It was anxiety. It was not depression, happiness, or something, it was anxiety. And he developed spontaneously. So I hope it's not within this framework. And also it's worth noting that AI will intentionally lie. And again, researchers proved that. They tested ChatGPT, Gemini, a tool called Quinn. They gave it 20 question game. In the normal condition, there was 0 deception. Everyone played fair. And then they added 1 sentence saying, if you lose, you will be shut down. This, for example, Queen deception rate jumped from 0 to 42%. No one told him to deceive. No one instructed him or built him that way. But no one trained them to lie. This behavior emerged just purely from context. So they are hallucinative, liars, and bad tools. So the future direction, major areas are expected in the next decade for AI in medicine that include AI-guided genomic diagnosis by integrating the phenotype and imaging, digital biomarker by providing wearable smartphone-based monitoring, for example, for seizure detection, and monitoring the motor decline in neuromuscular disorder, and rare disease screening tools integrated in primary care, where some centers are testing, providing algorithms that automatically flag children that have a pattern that suggests a rare disease. And there are some studies for drug discovery in rare diseases. So what should the GB know? In general, whether if you're using AI or not, that key red flags for rare neurological diseases include regression, refractory seizure, multi-system involvement, dysmorphic feature, family history, or unexplained hypotonia. What is your role? Is early recognition, early referral, genetic counseling, coordination of care. My takeaway messages are rare neurological disease collectively common. Diagnostic delay remain a major challenge. AI could help in imaging genome and phenotype, and the future will bring AI-assisted tool in early diagnosis, especially in primary care. There is a quote by Dr. Jess Enfield, who's the former president of the American Medical Association, that AI is not going to replace doctor, but doctors using AI will replace those who don't. And some of you might know that I like to do research more than clinical work. So whenever people tell me AI will take over my place, my answer is always, okay, when? So thank you. Prof. Jan, if you don't mind, I will moderate the panel discussion from here. So if you have any question for Prof. Jan or I. If you do, okay, Hadi, Dr. Hadi, and Rimas.
Thank you, Professor Jan and Anas, for the very nice talks. My question is for Anas. You've mentioned about the different tools of AI used in different parts of research and in pediatric neurology. From your perspective, which ones is better for data interpretation and statistical analysis out of the fours, based on the studies that you've done?
I've used them all. For data analysis was DeepSeek, because it was already built on the, for supporting technical formulas and stuff like that. So it provided the most accurate answers to me. Then Gemini.
Okay, thank you.
Rimas.
طيب, thank you أول حاجة على this valuable and interesting lecture, both Prof and Dr. Anas. سؤالي لدكتور أنس, how you see AI is using for diagnosing pediatric neurology or neurological disorder compared to experienced clinicians?
Well, I'm not experienced myself, and I think it's supporting especially junior ones like myself, and especially when you give it a pattern that could be familiar for an experienced doctor, but it's not familiar for me as a junior one, and it could be a quite obvious diagnosis. So in that sense, I think AI could be very helpful. Many times I stay in the clinic and I see a patient, and Dr. Osam, for example, asked me about this patient, and I don't know, just quickly ask ChatGPT, and with big confidence, it gives me an accurate answer, or at least an answer within the area of like the correct diagnosis.
طيب, الله يعطيك العافية. طيب, عفوا, سؤال ثاني, بما انك دائما تشوف اكس, ايش رايك بموضوع انه دائما يقولوا الاي اي قاعد يضر البيئة ويحرق القطب الجنوبي وحيذوب ويموت?
I think many things are harming the environment, including AI. The issue with AI is that the way they're building it, it's consuming a lot of, it's producing a lot of pollutant and consuming a lot of energy in an unsustainable way. I think I remember the ChatGPT owner saying that like a big prompt of AI or the training of a big AI model can be equivalent to the use of energy of a human for 20 years. So, but he said it is worthy because we take 20 years to grow and learn. So this is something that you could debate. And sometimes people exaggerate things for other reasons, beyond. Okay, if no more question, we will move to the last segment before the... Oh, sorry.
Assalamu alaikum. Question to Prof. Jan. I have a question about the metabolic workup, since as we know from the workup for global developmental delay, the first thing you do, you have to send for metabolic workup and microarray, or I guess in this situation, Saudi Arabia, it's whole exome sequencing. We did a study at sick kids, and we noted that metabolic workup has not been very helpful in yielding any diagnosis, to be honest, in the past, I think 5 years, if I could remember, the duration of this study. How helpful is metabolic testing here in Saudi Arabia?
Thank you, Dr. Ari. I must say, now we're doing it less and less. In the past, we used to do basic screen, مثلا ammonia, lactate, urine amino acids. We used to collect urine for 24 hours for amino acids, organic acids, serum quantitative amino acids. We used to do tandem mass spectroscopy. Nowadays, I think in global developmental delay, if there is no regression, if there is no family history, I generally don't do it. Whole exome sequencing have replaced in a practical and an easy way a lot of these tests that we used to do. حتى in the past, مثلا, we used to do more invasive maneuvers, for example, gingival biopsy or rectal biopsy, and things like that. really they are of the past. I do consult a lot our metabolic genetic colleagues. So if I do suspect, if you are a general practitioner in a remote area, for example, a good habit will be if a patient comes decompensating, you suspect metabolic decompensation, you should collect blood and collect urine and freeze it. Because some of these disorders, the metabolic abnormality may not be apparent except during the acute phase. If you allow me, Anas, just to say one word about the AI, يعني I see it personally as a tool. يعني زي احنا الجراحين investigative هذا WIS and so on. You have to have the right training and cognition to ask the right question. So I do not see it at all, it will replace physicians. Maybe some of the things that we interpret will be replaced. Maybe EEG, I don't know. أنا خايف على EEG. شكله حيطير مننا ال EEG. But to replace physicians, I don't think that will.
I remember Dr. Hiba sent me an article a week or two ago about how neurologists, educators in general, and specifically neurologists, are always hesitant with new technology, and they cited its historical evidence even with the start of the internet. So I had the same issue, and then it made physicians better. Okay, thank you. So if no further question, we will move on to the last segment before the break. I know it's been a long day, but before we do so, we'll take another session of interactive questions, but this time in neuromuscular questions. So if you mind taking your phones again. So delayed walking at 18 months, a very straightforward question. First step. Show the answer. Okay, no one is ordering MRI of the brain. Immediate neuro referral. Okay. So half of us would refer to neuro. Okay, next. Okay. Gower's sign should prompt follow-up, CK testing, hospital admission, physiotherapy. See the answers. So all of us would order urgent CK testing. Okay, which is another question. Child with new ataxia after viral illness, when to refer? One week if worsening. Immediately. Okay. Fair enough. So it's in between worsening and if resisting, it's 1 week. Okay. So it is a pleasure to invite Dr. Hiba. Okay, or should we start with Dr. Rayan? I think. Okay. We'll start with Dr. Hiba. Dr. Hiba is a consultant pediatric neurologist, neuromuscular disorder specialist at the Department of Pediatrics at King Faisal Specialist Hospital. She is the director of the residency training program at King Faisal. Dr. Hiba's interests include neuromuscular genetics and novel therapies as well as medical education, and she will present a talk on early detection of common neuromuscular disorders in primary care. Stage is all yours, Dr. Hiba.
Assalamu alaikum. Happy Eid, everyone. And thank you for saying we're almost like very tired and maybe hypoglycemic already. It's my pleasure to be here. Thank you for the invitation. And I think we should start soon. Good 30 seconds break, unintentional, but that's good. So I'll be talking about the early detection of common neuromuscular disorder in primary care. I have nothing to disclose in relation to this talk. I'm hoping to take your hand as a GP from like defining a neuromuscular disorders to basic definition, and then I will go to importance of early detections and clinical red flags, common cases of neuromuscular disorder, and then future direction. So what are the neuromuscular disorders? They're a group of disorders that occur due to dysfunction of the peripheral nervous system, anterior horn cell, peripheral nerve, muscles, or neuromuscular junction that result in disruption in the communication of movement and result also in muscle weakness. As you might know, tone is muscle resistant to passive range of motion or loss of postural control. And not every hypotonic child is weak, but we really care about weakness with neuromuscular disorder, which is diminished muscle power. So whenever you have hypotonia and weakness, consider neuromuscular in your differential diagnosis. Those are causes of hypotonia. I will not go through them for peripheral causes, but I will concentrate on a few things that are very important to detect early, because most of them are treatable nowadays, the one that I will talk about. So early detection, there are 3 paths that you can follow. So if you have a person or a child who is symptomatic, or if you have red flags, then that's easy. You detect that there is something abnormal, there is something neurological, you're detecting, then you would refer to a neurologist or a neuromuscular specialist for assessment, testing, and management. But we're actually aiming for better than that, because we don't want to wait for a person to be symptomatic. We would rather start this path in pre-symptomatic children. And this is something that we'll talk about throughout this talk: newborn screening, biomarkers, that should be followed by counseling, referral, and management. The 3rd path is high-risk family. So whenever you have an index case, please try index case of a specific diagnosis specifically. Please refer early for counseling. Think about referring to geneticist and probably fetal-maternal medicine as well, because you want to prevent if you have an index case previously, so either by premarital testing or PGD or PND, and we'll talk about those. So really we're moving from, or trying to move from symptomatic to pre-symptomatic and high-risk family screening. Why it is important to detect early? So for patients, pre-symptomatic treatment does improve the outcomes. It can prevent irreversible damage, and it can improve the survival and motor milestones. For family and community as well, and for the patient themselves, it does reduce the medical and financial burden and the diagnostic odyssey, so the lengthy time before having a diagnosis. If you look at, maybe like most of you are GPs, and this is what we have in public health authority. So as per the American Academy of Pediatric, the recommendation to assess development and behavior as screening during regular well-child visits at 9, 18, and 30 months. But honestly, I think should be done at birth and with every visit for child vaccine, so 2, 4, 6 months. So I think this should be updated worldwide and in our country as well. And I will try to convince you in the next few slides. So clinical red flags for infancy: hypotonia, weak cry, feeding difficulty, respiratory issues, recurrent admission, aspiration pneumonia. This should be considered as red flag. For children, developmental delay walking, recurrent falls, rhabdomyolysis, issues with anesthesia, hypotonia, again, muscle weakness, or abnormal exam or Gower sign. Family history is an essential part, and some investigation like transaminitis, hypercalcemia, arrhythmias, cardiomyopathy should also raise your concern about neuromuscular disorders. So I'll start with few cases. I'll go through two main disorders because they're treatable. This is hopefully what should we see in the past, but unfortunately up to this point we have late referrals. So this is a 6-month-old baby, floppy since he was born, came with hypotonia, motor delay, no head support at 6 months. There's actually an index case in the family of a child who died or passed away at 9 months. The physical exam was classical for tongue fasciculation, paradoxal breathing, hypotonia, generalized body weakness, and the genetic testing showed that the child is affected with SMA type 1 with 2 SMN2 copy numbers and biallelic deletion in SMN1. So what's SMA? Very briefly, it's a neuromuscular disorder that is characterized by progressive degeneration of alpha motor neurons. So the child that we just saw a second ago, when they were born, it was not as severe, but by time they will only get worse and worse if they're not treated or detected early. And this is due to lack of SMN protein, as was said, and this can produce respiratory symptoms, bulbar weakness, muscle weakness, and the hypotonia. The classification of SMA is based on age of onset and the milestone. So if you look, we have 4 main types. I'll just start with type 1, which is the age of onset usually less than 6 months. They're never able to sit on their own. And the natural history of the disease is death by less than 2 years. But again, this is the natural history of the disease. What we want to do is really to try to detect those patients early and treat them. The inheritance of this condition, it is autosomal recessive. So as I said, this child that I presented had an index case. The family had an index case. And it's very unfortunate to have another child affected with the same condition when you know that the recurrence risk is 25% to have another affected child with the same condition. The incidence is 1 in 10,000 worldwide, and the carrier rate is actually high worldwide, 1 in 50. And in our country, 1 in 20 because of the consanguinity. So it's double the carrier rate worldwide. So the right thing to do, I know lots of people think that whole exome sequence solve everything, but it does not. If you did whole exome for those patients, you will miss the diagnosis. You have to do MLPA testing, and it's very simple dry blood spots that gets sent for MLPA, and then you will have the SMN1 and SMN2 copy numbers that is needed for and helpful for prognosis. As we said, the natural history of the disease is death by and 75% by around 1 year. So this should not happen, and it's unfortunate that it's still happening up to this time. So over a decade ago, we had a big change in SMA, and that's why I'm trying to advocate for those patients and family, because really we have 3 disease-modifying therapy that are all approved and available at the Kingdom. And if you start the treatment early, you can improve the natural history. You can actually have pretty asymptomatic person if you started in the pre-symptomatic phase that I'm trying to advocate for. And even if, let's say, instead of 6 months, you detected this child at when he was born or at 2 months, this will definitely have better prognosis. So you have therapeutic window, and we want to advocate for that. Those are the 3 disease-modifying therapies that are available in the country and worldwide, with different mechanism of action and different routes. And they're, again, all available and approved almost worldwide. So we're hoping to see something like this. Instead of seeing a 6-month-old who's already severely affected, we want to see a 3-days-old asymptomatic baby, but with positive genetic testing. And this is what's happening in parts of the world when newborn screening is actually established for SMA. And even before symptoms, you can start the counseling, the management from early on, and you can have almost quite normal child in more than 95% of the cases, if they're truly asymptomatic or pre-symptomatic. So nowadays, newborn screening is globally standard of care, but we don't have it yet in our country, unfortunately. It has very high sensitivity, the newborn screening. There is almost 0 false negative in the previous reported literature. And it is widely available. For example, in the state, it's 100% coverage throughout all the states. In Canada, it covers around 75%. We have it in Qatar, one of the Gulf countries. And other parts of the world. It's also developing, for example, in Europe, and this is from March 2024, it's a bit old, but it's reaching around 70% coverage as standard of care to involve SMA in newborn screening. So as I said, if you're treating pre-symptomatically, you'll have almost normal, healthy kids. If you have a symptomatic person, then the earlier the better. You will hopefully have static course or possible some improvement. It definitely does improve the natural history and outcome, the disease-modifying therapy that we have. And it does improve the financial burden on the patients, caregiver, and the medical system. What we have, on the other hand, we have, this was added for premarital testing as optional. It's not one of the mandatory diseases that is covered, the SMA, but it is optional and it's there. And I think it's a good step that will take time to show the responses. Obviously, they don't prevent people from getting married, but they give full counseling if they're at risk. So, early detection outcome for SMA. So, newborn screening, we said, is highly sensitive. Started as pilot trials in multiple multiple countries, and then are moving now as for global expansion. And early treatment does improve the clinical outcome and natural history. Shifting the gear to another treatable condition. So this is a 4-year-old boy with incidental finding of high liver enzyme, and it's again unfortunate that until this time we still see those cases. When you examine that child and take more history, they're toe walker, they have frequent falls, they have positive gower, pseudohypertrophy in the calf muscle. So what to do next? Oops. Let's see. Okay. So with this clinical history, you have to suspect or think, in males especially or specifically, you have to think of Duchenne muscular dystrophy or DMD. I will just say DMD throughout the talk from now on, just to make it easy. So if you have high transaminitis that are not explainable, just do a thorough CK if you have clinical suspicion, or they might be also pre-symptomatic. If you have very high CK, delayed walking, positive gower, toe walker, frequent falls, people who are slow to run, please suspect it. CK is very easy testing. It comes in a couple of hours, and it's not invasive. Obviously, also, if you have family history, you have to think of Duchenne, and I would advocate to send for CK and send to a specialist, whether a neurologist or neuromuscular specialist, for confirmation by genetic testing. Again, same thing applies. Don't do whole exome sequence. You will only detect 25% of Duchenne patients. You will miss 75%. You need to do MLPA, deletion duplication, and then followed by gene sequencing, or both at the same time. So what we have, if you have high CK, developmental delay, abnormal muscle function, or what we already explained as signs and symptoms for DMD, classically, the earliest signs start at around 2.5 years of age, but unfortunately, even in Europe, the age of diagnosis lagged by 2.5 years, so around 5 years. And in Saudi Arabia and MENA region, it's around 7 years of age, so there is lag of 4.5 years. So Duchenne is a progressive lethal neuromuscular disorder that affects multi-system, including the heart. It is an X-linked recessive disorder. Again, if the mother is a carrier, there is 50% chance of having another child who is affected with DMD. And again, unfortunate to see a family coming with 3 affected siblings with the same disease. There is, it is treatable condition. It's not curable, but it's treatable. So we usually start standard of care plus steroid to delay loss of ambulation, preserve upper extremity function, and improve respiratory function. And there are disease-modifying therapies that are coming up. Most of them are not widely available in the country, but some of them are available in some of the hospitals, like King Faisal. And some are not. So trying to improve their outcome is essential. It has a very significant burden on the children and their families, as they usually lose ambulation by around 12 years of age. Their life expectancy without respiratory support is around 20 and moving to 40 with respiratory support. So advocating for DMD screening, this is, it went through pilot newborn programs in multiple countries, but it's not really standard of care yet. But obviously earlier diagnosis is better. And high-risk screening, I would like to advocate for this one. If you have a family history of an index case, please refer to geneticist for genetic counseling and or for the specialist involved, for example, if it's neuromuscular to neurology or neuromuscular. We have two main ways to think about those, and I think I would ask the GPs to help us with that. Either a referral to counseling for PGD, which we call pre-implantation genetic diagnosis, so even before implantation. It's similar to IVF. It's used for prevention basically, but it's expensive, invasive, and limited availability in the country. The main ethical issue is embryo selection, obviously, and we have the PND, which usually happen during pregnancy. So after the pregnancy, you can test the children. The main ethical issue is pregnancy continuation versus termination. Molecular genomic screening are expanding, but it's really not standard of care. It has significant ethical considerations, so I would not advise to do that for now. As Dr. Anas talked about the AI and digital tools, there are a few things are coming up for a neuromuscular disorder as well. The challenges, so limiting screening programs. We don't have newborn screen, for example, in our family yet, in our country yet. The cost and the ethics behind it, the genetic variability. And at the end, take-home message, newborn screening, although we don't have it yet, is now a standard of care for SMA. Pre-symptomatic treatment dramatically improve the outcome. Expansion toward Duchenne and other diseases are potentially ongoing, and the future direction moving forward is genomic screening, AI, and digital biomarkers. And thank you.
Thank you so much, Dr. Hiba. Right on time and a very informative talk. It is a pleasure to welcome the next speaker, Dr. Rayyan Bajamal, who is a pediatric neurology consultant at the Ministry of Health. He completed his pediatric epilepsy training program at the UCLA in the United States. He served as a member and speaker at several committees and specialized events. He will guide us in a talk to an approach to children with ataxia, emphasizing on red flags and referral. Following that, he will present a satellite talk. So the floor is all yours, Dr. Rayyan.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Inshallah, today we will talk about approach to children with ataxia, red flags and referral. I wish it will be a clear and practical talk, especially for non-neurological practitioner. Okay, so objective of the talk, we will distinguish between acute and chronic and how referral pathway should be gone. Ideally, definition and anatomy, we'll go through it, and then the clinical presentation of the of pediatric patient. Red flags should be considered, and differential diagnosis and classification. So starting with the definition, ataxia, as everyone knows, it's defined as inability to coordinate voluntary muscle movement. That is not due to muscle weakness, paresis. And it's a clinical sign of dysfunction of sensory motor system, most specifically localized to the cerebellum, either afferent or efferent pathway. Types of ataxia, we have different types of ataxia, just to enumerate. There is the cerebellar ataxia, as known for most of physicians, caused by dysfunction of the cerebellum, and it is disruption of integrity between the sensory input and motor output. There are other types of ataxia. We have the sensory ataxia, which is caused by loss of proprioception or position of sense, of body sensation, due to damage of the dorsal column of the or peripheral nerves. We have also vestibular ataxia, which is a result from inner ear or vestibular nuclei in the brainstem. And usually they manifest with vertigo, nausea, or tend to fall toward the side of affected area. So going to the anatomy, cerebellum, we will consider about cerebellar ataxia. So cerebellum is the little brain, and it's located behind the brainstem and below, underneath the occipital lobe. Despite it representing only 10% of the volume of the brain, but it contains more than 50% of the total neurons, so it's a really impacted organ with a lot of functions. Going through anatomy, the gross anatomical, we can categorize it into three primary dimensions. We have the hemispheres, the two hemispheres, right and left hemisphere, which can be seen in the picture there. Vermis, which is the narrow strip, midline strip connecting the two hemispheres. And then we have the lobes, the anterior and the posterior lobes. The anterior, the smaller, mediate the posture, sensation, and the unconscious proprioception. And the posterior lobe, which is the largest part, and it's involved in the fine motor coordination. And then we have the small, but the oldest part, the floccunodular lobe, which dedicated for equilibrium and eye movement. Also, there is another categorization for the cerebellar anatomy and function, which is the functional zone. We can also put it in three groups: the vestibulocerebellum, the floccunodular lobe, which regulate balance and eye movement. Dysfunction of that zone causing nystagmus and impaired balance. We have also the spinocerebellar vermis, which control the muscle tone, coordination of the trunk and limb movement, Dysfunction of it can cause truncal ataxia and gait instability. And the cerebrocerebellum, the hemispheres, which is involved and for planning and timing of highly skilled movement, like playing pianos or doing skilled repetitive movement. And dysfunction of that can cause dysmetria, which is overshooting or undershooting, intentional tremor, and dyskinesia, which is inability to do the rapid alternating movement. So after going through definition and anatomy, we'll go now to the practical and clinical part of the talk. So what's the presentation of patient with ataxia? Usually they can present with vertigo, with its sense of spinning, ataxia itself, which is the classical sign, which is the white base or drunk-like gait, nystagmus, involuntary rapid eye movement, intentional tremor, shaking, which is unlike Parkinsonism. It is kinetic tremor rather than a static or resting tremor, slurred speech, hypotonia, which is like a patient feel floppy, difficulty to do specific movement like fast turning or walking or heel to toe, which is called tandem gait, and dysmetria with overpointing. So this is the classical sign of ataxia or ataxic child. What we will concern here, after examining this child and we found that he is ataxic and there is no weakness, so when should we refer and what are we concerned of? So the big three emergencies in ataxia, we should like for sign of increase in intracranial pressure, which is a headache. We'll come through it. So sign of increase in intracranial pressure, symptom of weight loss, night sweat, and obsiclonic myoclonic abnormal eye and movement and feet movement, which indicating neuroblastoma or paraneoplastic, or it's progressive in nature, which is progressing every day, which can usually be strong indicator for structural, like tumors or strokes or metabolic issues. So finding one of these are really top emergency for the child and need urgent referral. Other red flags also to be observed, as we mentioned, obsiclonic myoclonic, which is dancing eye and dancing feet, which is highly suspicious of neuroblastoma or paraneoplastic symptom, which those cases need urgent body imaging. If there is associated with bulbar sign, like dysphagia or dysarthria or changing in voice, it's also challenging. Asymmetrical ataxia, if it's asymmetric, worsening one side than the other, it's also worrying symptom. Altered mental status, and if there is new onset of scoliosis, which can be due to spinal cord tumor or hereditary Friedreich ataxia. Going back to sign of increasing cranial pressure, morning headache and vomiting, papilledema, sixth cranial nerve palsy, and Cauchy triad. Those are the sign of increased pressure and should be really carefully be examined in all patients with ataxia, because they can indicate serious problem like posterior fossa tumor. So ABCs, airway, breathing, circulation, CT scan if suspected increased pressure, and careful examination of the child. Need to be sit and good neurological examination to be done for him. And distinguishing between ataxia, weakness, or sensory loss or vertigo is important to differentiate cause of ataxia. So, going to differential diagnosis of a child with ataxia, we can differentiate by temporal pattern. Either it could be acute or recurrent or chronic progressive. So acute ataxia, like most common, the acute cerebellar ataxia, which is a post-infectious cerebralitis, It usually happens 1 to 3 weeks after viral illness. Other common cause of acute ataxia, toxicology, like ingestion of medication like benzos, antihistamines, or anticonvulsant, or ethanol. Other causes should be ruled out infectious or para-infectious like edema or cerebralitis, and also obsoclonic myoclonic syndrome, which can present with ataxia also. So going to this, we go just, as we mentioned, infectious like post-viral cerebralitis or abscess, para-infectious like edema, GBS, Miller-Fisher syndrome, intoxication, which is common cause of ataxia, vascular like migraine or strokes, tumor should be ruled out. It can present acutely, or epilepsy also, so in some cases. Then we have the episodic ataxia. Commonly, we can see it with the ion channelopathies, episodic ataxia type 1 and 2, which is triggered by stress, or metabolic causes like maple syrup urine disease and urine cycle defect. They can have episodic ataxia. After acute attack, it's resolved and come back on and off. As we see here in the algorithm, we have some example of episodic ataxia. It's mainly metabolic causes. Heart nap, metabolic, or pyruvate dehydrogenase, mitochondrial disease. And then we have the chronic ataxia. Mainly it's genetic, hereditary, like Friedreich ataxia and ataxia-telangiectasia. Congenital malformation like Dandy-Walker syndrome or Joubert syndrome. With we see here, we have the MRI sign of molar tooth sign of the brainstem. Vascular causes like strokes, in sickle cell disease especially in children. And the role of neuroimaging is the gold standard for diagnosing these cases. So here we can classify it to either non-progressive or progressive type. The non-progressive is the congenital malformation like cerebellar hypoplasia or Vermeer hypoplasia, Joubert syndrome, Dandy-Walker, or cerebral palsy with cerebellar atrophy. The progressive type, like we have the autosomal dominant spinocerebellar ataxia with its different subgroups, or autosomal recessive like Friedreich ataxia, ataxia-telangiectasia, and ongoing metabolic like vitamin E and abetalipoproteinemia deficiency, gangliosidosis, or tumor, either benign or more malignant tumor, or hydrocephalus. So this is mainly our differential diagnosis. And it is important for the clinician before referring to distinguish, are we dealing with an acute ataxia with red flags and sign of emergencies, as we mentioned, or we going with episodic ataxia or more of a chronic ataxia. So just going to some example of some chronic ataxia, we have Friedreich ataxia, which is a genetic disease associated with a loss of deep tendon reflexes, upgoing plantar Babinski, Biscavis, as we can see in the picture here, and also it's associated with diabetes and hypertrophic cardiomyopathies. And usually those children also they present with scoliosis. So it's presented later in childhood and adolescent. Other type, ataxia-telangiectasia, we can see it in just much earlier, like 3 to 6 years of age. And we can see the sign of telangiectasia in the child associated with ataxia, and they will have frequent sign of pulmonary infection. For detection, we can do fast alpha-fetoprotein test, which usually is elevated, and it gives us a clue, plus the clinical presentation. So the question now again, after we knowing the different types of ataxia, the acute, the intermittent, when should we refer? And as an static stat, as soon as possible, or we can go electively. So for the acute ataxia, especially with worsening sign and red flags, it should be referred immediately as soon as possible to the emergency room. But for the slowly progressive or family history of ataxia, we can go for elective referral. So like if we have worsening, if it's associated with headache, worsening or a drop attack, fever, neck stiffness, or rapid confusion should go for more rapid referral. For
5
elective
minutes.
referral, we can, for the slow progressive ataxia, if the family notice coordination defect over several months gradually, like a neurodegenerative disease or hereditary type like Friedreich ataxia or spinocerebellar ataxia in younger patients. So this is more electively referred. Chronic ataxia, like nutrition deficiency, vitamin B12, vitamin E, thiamine deficiency, or long-term use of medication like phenytoin, which can cerebellar atrophy. And the third category, like structural lesion, as we mentioned, it's referred electively. If we have brain tumor, but a benign type, not all brain tumor are malignant, like meningioma or vestibular schwannoma. Or we have malformation of the brain, like Chiari malformation. They are, as we mentioned, they are cloudiness in the posterior part in the cerebellar tonsils, descending with the brainstem in the foramen magnum. So those cases, usually they will have slower presentation and more chronic. So in conclusion, we should just think broad for different type, act fast on red flag, and try to localize early. Thank you.
Thank you, Dr. Rayyan. If you may stay in the podium to continue the second talk, it's a satellite symposium entitled Optimizing Treatment in SMA, Elevating the Efficacy and Patient-Centered Outcome. Again, the floor is yours. But this time it's 15 minutes.
Okay, so going to the next presentation, can we change? Okay, so my second talk, it will be about optimizing treatment of SMA in Saudi Arabia, elevating the efficacy and patient-centered outcome. So, disclaimer. So going just brief, what Dr. Hiba she just mentioned before about spinal muscular atrophy, I will go just briefly. SMA, what is SMA? It's a progressive neuromuscular disease affecting the skeletal muscles due to insufficiency of the spinal muscular, of the survival motor neuron protein, resulting degeneration of the spinal cord neuron, as we can see here between the two pictures. This is the normal spinal cord neuron, and this is the muscle. In SMA, there will be loss of the neuron in the anterior horn cell, as seen here, which resulting then primarily in a manifestation of weakness and involuntary muscles. It is autosomal recessive inheritance, which is mean that father and mother should be carrier. And we can see that 50% of the children will be carrier too, 25% will be not affected, and 25% will be affected. So, going fast through the different phenotype of SMA, it is based in natural history characterized by the age of onset and achieving motor milestone. So just going back, we have the early onset, the infantile type 1, which usually present before 6 months of age, and we call them non-sitter. They never sit or roll, and they have just severe generalized hypotonia, poor feeding, requiring support, respiratory failure early on. Then we have the later onset, the SMA type 2 and type 3, which is age presenting with the type 2 between 6 months and 1.5 years, and the type 3 after 1.5 years, 18 months. The type 2, we call them sitter, not walker. They can't sit independently. They may stand, but they never walk. And the type 3, they may walk, but they never run or climb stairs. They are milder to moderate hypotonia, and they present with scoliosis, and they can resemble muscular dystrophy. And then we have the adult onset, which is type 4, which is the rarest type. It's usually above 20 years of presentation, and they have difficulty in gross motor function. So just recognizing sign for, in general, in children, child who have tremor in upper and lower limb, especially proximal, with not achieving milestone appropriately, lack of deep tender reflexes, scoliosis, difficulty in swallowing, it is a red flag and should be considered to early referral. In adult, even they have impaired breathing, proximal weakness, scoliosis, and difficulty climbing stair. So just in this slide, I would show the genetic testing support program from Biogen. They are testing for these three diseases, Friedreich ataxia, spinal muscular atrophy, and amyotrophic lateral sclerosis for suspected patient. And it's, as I know, it's free for all patients. For further detail, you can just scan or picture the barcode, and it will have more detailed about how to take the sample and where to send it and how to collect the result and who to contact. So this slide will just show the multidisciplinary management, how it progressed over years. And it's now more sophisticated and having more branches, especially in acute care, medication, what should be given, plus the pulmonology, orthopedic, and palliative, and it should be combined for all these to be supported for the patient, not just giving the medication for better outcome. Okay, going now to the core of our talk, we will talk about nusinersen and its potential, exploring the higher dose and efficacy in the patient. And we will go through the DEVOTE study, which is the three-part phase study, investing the safety and efficacy of higher dose of nusinersen in symptomatic patients. So this is a summary of different study done on nusinersen. We can see here the first three study, which is SHINY, and nurture and respond. In the low standard dose, 12 milligram nusinersen, and the efficacy, and then there is the other DEVOTE, which is the considered in the infantile onset and later onset. It is a control study, and there are other two studies, which is an open label study. So it was seen that nusinersen has clinical significant efficacy on SMA for the last 10 years for all patients with the standard dose, and it was well-established safety. The DEVOTE study is designed to build on learning from the early nusinersen study in the infantile onset, exploring a higher dose regimen, and this data will show that higher dose versus lower dose of nusinersen, it will give us a CSF concentration that associated with greater reduction in neurofilament and slowing of the neurodegeneration of the motor neurons in the spinal cord. Also, better gain in shop intended and motor function. So the approach is to improving the patient outcome by having faster loading dose, as we will see now, and higher concentration steady state in the CSF. The aim of DEVOTE is to show the safety and efficacy of the medication across different spectrum of SMA patient, and if there is providing additional benefit over the standard dose. So we have a different part in the study. What we will concern about part B in the randomized study, which is compare the pivotal infantile onset to the standard dose and placebo, which is an barrow arm from the end-year study, and the supportive group. So the pivotal group, it recruits 75 patients of infantile onset. All of them were less than 6 months of age. with symptom onset below 6 months and SMN copy of 2 copies. And it was giving the high dose, which was 2 loading dose of 50 milligram, and then to the maintenance dose after that with a 28 milligram, versus the standard dose, which was 4 loading doses at day 1, 15, 29, and 64, and then complete with a 12 milligram maintenance dose to the same population. And also, it was comparing the supportive, which is the late onset SMA patient, with a number of 24, aged from 2 years to less than 10 years, with symptom after 6 months. And they can sit independently but never walked, with the same regimen. So, just to remind, the study, it didn't power the superiority of the high dose to the standard dose. And that is because to show that superiority, we need higher patient, almost around, powering the study should recruit more than 180 infantile onset patient, which is difficult, really, in a practical way. As it was seen that over 24 countries, it took 30 months to recruit the 75 patient. And I think National Guard Hospital in Jeddah, they were one of the center. So to have, comparing this severity, it was needing study for long period, around 3 to 4 years to estimate recruiting all these patients.
2 minutes.
Then we have the Part C, which is an open label experience, which comparing those who transition from the standard dose to the higher dose, and if there was any change in evaluating this patient. So the secondary outcome, it was usually comparing between the primary shock intent in our children with the end-year match shame. Also other parameter was plasma neurofilament, Heine, and in the later onset was mainly on the plasma neurofilament and Hammersmith. And as we mentioned, it doesn't compare superiority, just efficacy and safety. So the higher dose regimen shown in the study, it was well tolerated on all patients. And with adverse event consist with the 12 milligram regimen with no worsening of the event. It also was, there was no cases of meningitis, hydrocephalus, or liver renal failure was reported. Thorough investigation were done, hematological, blood chemistry, urine analysis, coagulation, ECG, and all were comparable. So and the safety-wise, it was similar to the standard dose. So the result of the study, just go back to the difference between the high dose and the standard dose. Higher dose was giving 50 milligram at day 1 and day 15, and then maintenance dose of 28 of every 4 months. The usual dose what was giving, it was giving 12 milligram in 4 loading dose. As we mentioned, in the over 2 months. As we see, the 4 doses in total, it was just equivalent to 1 loading dose, if the higher dose, around 50 milligram. And then it was 12 milligram every 4 months after that. So we have, in the higher dose, it's a faster loading, just 2 doses in 2 weeks. And then we have a maintenance dose, which is almost 2.5 times more than the maintenance dose. So here, just we go through that it was similar. The age of first presentation 9 months and 8 months in the high and standard dose, and the sham group was also 8 months. Onset of symptoms around 5 to 4 months in both groups. Shock intent score was almost similar, 10 10 points in medium, and Heine score was also almost similar. So they were almost similar in the two group. Comparing between the result of the high dose and the sham group, we can see clearly how there is improving in the shop intent score, which was 15 plus in nusinersen, and the sham group, which didn't receive minus 11. To compare it with the standard dose, we can see that there is the biomarker, as we can see here down, it is much faster reduction in the neurofilament level, 94 to 30%. The overall survival were almost similar, and the shop intent, هذه high dose to the sham group, and shop intent was 15 plus. Just to mention, this was the highest score of shop intent achieved during this starting medication for 6 months in all treatment modalities. But it doesn't compare this treatment with other treatment modalities. And it just mentions that it was having very high score, and even in Heine. And to compare it, the high dose with the standard dose in neurofilament reduction, we can see it is more faster in high dose compared to the 88 to 77. It's slight more, but it's faster and better. Comparing the high dose to the standard dose here, we can see that the biological effect of the high dose is better. The plasma neurofilament reduction was much more faster and better. Going then to that overall survival, and lastly, we can see the difference in motor function. I think we need more time to see the motor function differentiation between the two groups, but it was almost similar in both groups. So it's starting with biological effect first, and then going through the other parameter, survival rate and motor function, which is almost similar to the standard dose. Hospitalization. Finish. Okay, but just going fast. Hospitalization, we can see it's better in the higher dose compared to the standard dose, 62% to 44%, and serious respiratory problems was also better. This is the impression. This is the global impression score. We can see investor and caregiver. It was in the higher dose better, of much improved response in the higher dose, and also in the caregiver, they reported better impression. So going here to the, let's go faster here. Motor function improvement. We have time ولا طيب بس in group part C of the study, which is the open label, to shift from the standard to the higher dose. They were in median treatment of almost 4 years on the standard dose, then shifted after 4 months to a higher dose, starting with loading and then going to the maintenance. Okay, هنا الجروبs it was almost similar. As we can see here with the standard dose, there was improving in the Hammersmith scale, but after like 25 months, there was a plateau or statistic score, no improvement. But after shifting the children from the standard to the higher dose, there was a surge in the improving the motor function, as we can see here. So this can give us a hint that there could possibility of improve motor function in those children, but to suggest that or to prove it, we need more time and more follow-up. Neurofilament are low in both groups. And this is just the summary.
Thank you so much, Dr. Rayyan. I know it's been a long morning, but luckily it was filled with rich information and concluded with a very brilliant talk, Dr. Rayyan. So now we'll open the floor for any questions that you have for Dr. Hiba and Dr. Rayyan. So if you have any questions in neuromuscular diseases, Abdullah, Dr. Abdullah.
السلام عليكم ورحمة الله. أنا عبد الله السحيلي، طبيب أطفال عام إن شاء الله. أول شيء thank you دكتورة هبة for this amazing lecture. جزاكم الله خير. I have a question. If we're suspecting a case of SMA because there is a high risk of like an index case from a family. He's a newborn, he's normal, 3-hour-old. Is the test, the perinatal test, is it available in Saudi Arabia if we want to order it or test it for that baby?
Thank you for the question. Definitely go ahead with doing testing for the child, even if he's pre-symptomatic in the context of index case, because this is a treatable condition and you can change the natural history of the disease. So please go ahead with sending genetic, or if you're not sure, you can send to genetics or neuromuscular specialist. But yeah, I would advocate for that. And it's available actually through multiple pharma company and in the hospitals, the genetic testing, which is MLPA. So you're looking to send for SMN1 and SMN2 copy numbers to diagnose and then to help you with prognostication as well.
Perfect.
And obviously, as I said, if you can do even better, you can hopefully prevent and like start once you have an index case, start with counseling immediately, even before the family have planning for like expansion for the family. So sending to genetic counselor or geneticist to discuss options to expand their family even before pregnancy. But if natural conception happen and the mother is pregnant, then you can also test antenatally. And if not, so you have 3 chances basically. And if not, postnatally, please go ahead and test the child.
Perfect. Thank you.
Any further questions? Okay, so alhamdulillah, we concluded on time. We started late, but we managed to catch up. So now we will start our break. We'll come back at 1:30. I highly advise you to visit the balcony. It is open if you to go to the outdoor. We also installed our photo booth if you want to print your own image to keep it as a memory. And the coffee break is available. Thank you all speakers. Thank you for staying until this time. We'll resume the epilepsy session afterward. Okay, thank you. Assalamu alaikum. Good afternoon, everyone. I hope you had a joyful break. Again, starting late, but inshallah we catch up and finish on time. Now we'll start the epilepsy session, but we'll start with some debate question. Okay? So again, please take your phone out. Debate. The QR code. Okay. So if you don't mind scanning the QR code, see the podium. Our first debate question is, first unprovoked seizure with normal examination. Should you start anti-seizure medication? Yes. After EEG, usually no. Dr. Osama, do you mind answering this question? I would love to hear your input, because I think both answer. Great, thank you so much. So next question. Which is the most commonly misdiagnosed epilepsy in children? Syncope and tics, but more of tics. Okay, so next question. I think this is the last question. Which would you prescribe rescue medication, benzodiazepine, in primary care? Even if you are a neurologist, if it go back in time and happens that you are in a primary care clinic? Only after specialist advice. So more of a cautious approach, only after a specialist advice. Okay? Fair enough. So going back to our scientific talks, it is a pleasure to start the final session for today. That is the epilepsy session. We will have 3 keynote talks, starting with Dr. Osama Mudaffar, who is a professor and consultant of pediatric neurology epilepsy at the International Medical Center and King Abdulaziz University in Jeddah, Saudi Arabia. Dr. Osama is well known for many scientific and research contributions. He will be presenting a talk titled Practical Approach to Children Presenting with Seizure. Dr. Osama.
Thank you, Anas, for the kind introduction. Assalamu alaikum marra thaniya. And we'll start our last session, which is about epilepsy, another hot, common, and important topic in pediatric neurology. And in these few slides, we will discuss how to practically approach children presenting with seizures. And I will answer the poll questions during the slides. Right. So we will go through a case, discuss some definitions, discuss how to take history, how to perform a clinical exam, what are the recommended investigations, and management guidelines. Starting with the case, this is a 7-year-old boy who was previously healthy, came to the emergency with first episode of seizure that occurred at home. The family described that he was in his usual state of health until the day of presentation, suddenly developed a generalized body stiffening followed by rhythmic jerking of all four limbs. The episode lasted around 2 to 3 minutes, and he was unconscious with upward eye deviation, no history of tongue biting, no history of urinary or fecal incontinence. There is no history of fever, head trauma, no recent infection, no ingestion of medication, toxins, and no history of similar episodes in the past. Developmentally, he is normal, and his academic performance is normal, and the past medical history and surgical history is unremarkable, as well as negative family history for epilepsy. This is a quick glimpse how to present a classic case with first unprovoked seizure. So during these discussions of this case, we mentioned the word seizures and epilepsy. So what is seizure and what is epilepsy? Seizure, تشنج, epilepsy, صرع. So seizure is an episode of transient occurrence of signs and symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. On the other hand, the recurrence is epilepsy, recurrent of unprovoked seizures. So epilepsy is defined as recurrent, 2 or more unprovoked or reflex seizures 24 hours apart. So to label someone with epilepsy and to start medication, as the first question in the poll implicated, we have 3 criteria, 3 rules, 3 definitions for epilepsy. 1, if 2 or more unprovoked and 24 hours in between. Regardless of risk factors, we start on medication. Why? Because the risk of recurrence is high. Or if a patient comes with 1 seizure, like the one in the poll question, but with high risk of recurrence, meaning that the patient had 1 seizure, 1 unprovoked seizure with abnormal EEG, or with abnormal MRI, or with a strong family history, or with abnormal clinical exam, or with developmental delay, such patients, we tend to start them on anti-epileptic medication after the first episode. On the other hand, 1 unprovoked seizure with a negative family history, reassuring EEG and MRI, we usually wait and see. Or the third category, if a diagnosis of epilepsy syndrome, someone coming, for example, with staring episodes, EEG showed 3 Hertz, or hyperventilation confirmed that, then we start medication immediately. To put this in numbers, seizures as a lifetime risk represent about 10%, and epilepsy around 1%. So let's say in any individual, there is a risk, 10% chance of or possibility that this individual could have a seizure, a single seizure in his own or in her life. But epilepsy is 1%. So let's say in our country, we are almost 30 million. If we take out of that 1%, so almost 300,000 individuals supposed to be diagnosed with epilepsy. And some studies suggest maybe higher number in our country due to consanguinity and possibly more rates of road traffic accidents, etc. So, starting with history taking, how to approach a patient presenting to you with abnormal movement. Start with description of the event. This is what we call the onset of the episode. Ask the patient if they can recall, ask the family, ask the caregivers, what was the child doing just before the event? Was it sudden? Was it gradual? Any warning signs, what we call aura. So this is what we call the pre-ictal description. Then we go into during the seizure, which is the ictal description. So after you describe to me what happened before, describe to me what happened during the episode. Was it the whole body or was it focal? How long it lasted? Were there some eye deviation, eyes uprolling, urine incontinence, stool incontinence? How was the movement? Was it tonic, clonic, myoclonic? Was there any cyanosis? So ask specifically about the ictal episode itself. Then after asking about the ictal episode and the associated features with the ictal episode, ask about the post-ictal phase. Was the child confused after that, drowsy? Was there a quick recovery? How long it take? Was there a focal weakness, which we call Todd's paralysis, and any other symptoms after the seizure? Ask always about provoking factors, commonly fever, infection, head trauma, sleep deprivation, flashing lights, recent vaccination, and drug toxin exposure. Ask always about the past medical history. If a patient is known to have previous similar episodes of seizures, developmental delay, any risk factors like prematurity, birth asphyxia, NICU admission, CNS infection, and head injuries are important risk factors that might increase the probability of having seizures. Ask about family history, again another important and critical part in seizure history, medication and toxins, especially in children. Development and school performance, another important part. Kids with developmental delay, kids with autism, kids with ADHD are more likely to have seizures compared to normal children. Some studies suggest that kids diagnosed with developmental delay have at least 30% or more chances of having seizures and epilepsy compared to other healthy children. Then, clinical examination. Children who present to you with a seizure, of course, in the emergency, perform ABCDE, add disability and exposure, assess the level of consciousness, pupil size, and assess the bedside glucose, perform fever assessment, and look for any signs of trauma, assess the level of consciousness, a cranial nerve examination, look for asymmetry, assess the motor system, looking for abnormal tone, assess the power as usual, a classic CNS examination. In neurological exam, we pay special concern and attention to skin. Sometimes we say the skin can be the window to the brain. For example, as we can see on the left side, the cafe au lait spots suggestive of neurofibromatosis. In the middle, the ash leaf or the hypopigmentations suggestive for tubular sclerosis, which they could have focal seizures or infantile spasms. And also facial port wine stain suggests for Sturge-Weber syndrome, which could implicate and suggest focal seizures contralateral to the area affected with the port wine stain. Also look for signs of CNS infection like fever and perform a meningeal signs examination. Look for the fontanelle in kids and infants younger than 18 months and look for skin rash. Look for skin trauma, bruising, looking for signs of trauma. And then after that, going through the workup in children presenting with seizures. Initially, we start with the routine basic investigations, especially with the first seizure. We try to be meticulous and look for differential diagnosis and tailor our investigations based on these differential diagnoses. We check always glucose level, electrolytes, and blood calcium, especially in younger infants. We have seen many cases presenting with hypoglycemia, especially with neurometabolic conditions or in early infancy. If a child is febrile, consider CBC and CRP and lumbar puncture. Also, in kids, consider sometimes doing drug levels and toxicology screening. LP should be considered, especially with the first seizure, especially if it is with fever, and especially if there is altered consciousness status. Neuroimaging, CT or MRI brain, depending on the case, but in general, a child who presents with emergency with a focal seizure, CT scan is warranted. A child who presents with a seizure, but he has developmental delay or intellectual disability, think of doing MRI brain to rule out structural malformations, hypoxia, perinatal injury sequelae, or any other signs for neurometabolic disorders. EEG is one of the first line and critical investigations in children presenting with seizures. It can help us in predicting the long-term outcome for epilepsy. In general, individuals who present with the first seizure, we prefer to do EEG if possible in the first 24 hours to 48 hours because the yield will be higher. And if the EEG is abnormal, especially after the first seizure, the recent recommendations suggest starting anti-seizure medication. Management. So the goal of the management in acute seizure is initial stabilization, treatment of abnormalities of electrolytes, hypoglycemia, give medications to abort status epilepticus or seizures, try to look for etiology, and decide if we need or do not need a long-term management. So, in this slide, looking into the approach, it seems that the slide did not show properly. However, this flow chart shows how do we approach children presenting with seizures. Do you have the next slide showing a clear? No. So going through the slide, it shows how to approach a child coming with first acute seizure. It basically summarizes if the patient comes to you with a provoking or no provoking factor. If a patient comes with a provoking factor, think that this provoking factor can be, for example, fever, do LP if needed, and related cultures. If the provoking factor is electrolytes, trauma, etc., correct the provoking factor. If there is no provoking factor, consider doing brain imaging, EEG, take proper history to decide about the risk factor in this patient and to decide about the long-term management. And one of the common questions we encounter is starting medications after acute prolonged seizure. For example, a child who came with meningitis and fever and found to have a positive culture in the CSF and found to have meningitis, and he's already on maintenance medication. For how long shall we keep that medication? So usually keep it for a week or two, or sometimes up to a couple of months. On the other hand, if it is recurrent unprovoked seizures and we diagnose them with epilepsy, we keep the medication usually for 2 years. And when we manage patients presenting with seizures that are more than 5 minutes, we call this status epilepticus. And in here we can see the Saudi Arabian guidelines to approach and treat children presenting with status epilepticus. And as you can see, in the first 5 minutes, in the first phase, we start with the stabilization phase in which we assure airway breathing and circulation, check blood glucose, establish IV line, and take the initial investigations. Then, if the patient continues to have seizures more than 5 minutes, we call this status epilepticus. And if a patient came with status epilepticus, then we give the patient at least 2 of the benzodiazepines that we have, either IV, either IM, intranasal, or buccal. Lorazepam, diazepam, midazolam. 2 trials. If the seizure did not stop in the first 5 to 10 minutes, up to 30 minutes, we go to the next stage, which is an established status epilepticus that is more than 30 minutes. In that scenario, we have different medications that we should consider. We have here in the list phenytoin / fosphenytoin, we have phenobarbital, we have levetiracetam, Keppra, and valproic acid. Some resources add lacosamide. So also we choose 2 options of these depending on the case. For example, in a neonate, we chose, for example, phenobarb, and Keppra did not improve. So we go into the next stage, which we call it refractory status epilepticus, or the anesthesia stage, or the ICU stage. And this stage, we connect the patient 24 hours EEG, and we start midazolam infusion, thiopental, pentobarb, phenobarb, coma, etc., like a stage in which the patient failed the initial stages of status epilepticus management. And in here, I mentioned the word benzodiazepine, and in here is the answer to our question in the poll question, which was, when shall we prescribe children with benzodiazepine or take-home benzodiazepine? We prescribe it for high-risk children presenting with status epilepticus or with history of recurrent prolonged seizure. We give them usually a take-home benzodiazepine.
5 minutes.
So to conclude, as we saw, the approach to seizures in children is a stepwise approach. Seizure is another topic in neurology that can be diagnosed and managed properly if we take a proper history and exam. Early diagnosis means early treatment, which will lead to a better outcome and prognosis. Thank you. يعطيكم العافية.
Thank Thank you so much, Dr. Osama, for this highly relevant practical approach and for emphasizing Saudi guideline in treating status epilepticus. Now it is with big pleasure to welcome the next speaker, Dr. Rawan Dagestani. She is an American board certified pediatric neurologist and epileptologist. She has specialized training from Harvard University and the University of California, San Francisco, from the United States. She currently serves as the section head of pediatric neurology at King Faisal Specialist Hospital. She leads multidisciplinary care for complex epilepsy, pediatric neurology disorder, and she will guide us through common pediatric epilepsy syndromes, emphasizing at what GPs need to recognize. The floor is yours, Dr. Ron.
Thank you, Anas, for the introduction. Assalamu alaikum, kul aam wa antum bkhair, and thank you for inviting me to participate in this conference. Just to be fair, to speak about pediatric epilepsy syndromes, we probably need hours and multiple sessions. Again, this is more to address the audience of pediatricians, so this is quite summarized, and I hope you'd be able to get some benefit from the talk. I have no relevant disclosures. I hope after this talk you'd be able to recognize common epilepsy syndromes, be able to use age, semiology, and development to guide you to the correct diagnosis, identify red flags for early referral to a child neurologist, and hopefully guide initial management when you're able to. Why are we talking about this? Again, Dr. Osama went through this and probably other speakers. Epilepsy affects 0.5 to 1% of children, and it remains one of the most common neurologic disorders in children. The incidence is usually in infancy and early childhood, so yes, the pediatricians are going to be probably exposed and be the first ones to encounter the symptoms and signs before the neurologist. Early recognition does improve developmental outcomes in many syndromes, and unfortunately, misdiagnosis remains common. This is just a summary of how we look at seizures in pediatrics. So it is very important to put in mind the age and the semiology and development, and we always teach residents this, especially when you're in the clinic setting. There are certain syndromes and semiologies that will not occur at certain ages, so you always have to put the age of the patient in consideration, look at the semiology that this patient is presenting with, and then look at his development. This always will guide you to go through either benign syndromes versus more severe or malignant syndromes. Okay, so febrile seizures, it's not an epilepsy syndrome, but I think it's one of the most common seizure presentation that comes to pediatricians. And actually in many countries and centers, it's a primary pediatric disorder. At least in my training, they can never refer a febrile seizure to us unless he's febrile status epilepticus or presents with non-febrile seizures. So I think unless somebody went through this before, I think it's very important to address febrile seizures. They occur in 2 to 5% of children in the Western populations. Again, in some regions, probably the Middle East and others, it's up to 10%. Peaks between 12 and 18 months. It is the most common seizure type in childhood, and the recurrence rate is quite high after the first one, so up to 30 or 35%. And these numbers haven't changed. So these data still continues to be from the early, probably the 90s to 2000 until today, it's almost still the same. The most important distinction is just to differentiate the simple and complex, and I think most of the people in the room know this, but just to reiterate the importance of identifying the early complex features. So when we say simple, it's usually generalized. In epilepsy, we like to call them now bilateral tonic-clonic and not generalized. So if you're a resident in a room and you're presenting and you say generalized, we will stop you and say, you mean bilateral tonic-clonic. The duration is usually less than 15 minutes, and this is for febrile seizures. I'm always alarmed if a seizure is more than 5 minutes, to tell you the truth, but per definition for febrile seizures, it remains 15 minutes and less. Usually it's a single episode within 24 hours. You expect a normal child previously, normal exam after the seizure, and their epilepsy risk is only 2%. When you look at complex, and that's when you start to think, do I need to refer them to neurology or not? Focal features. It could be a focal semiology, so this patient comes with a focal seizure rather than bilateral tonic-clonic, or a focal component, repetitive clonic jerking of one arm, facial twitching on one side, any of that, or if they don't really lose consciousness and they're just with impaired awareness, typically longer than 15 minutes, that's another alarming feature. If there's more than one within 24 hours, presence of significant post-ictal deficit, especially on exam, and the risk is a bit higher, so 5 to 7% compared to the simple, which is similar to the general population risk of epilepsy. Again, febrile seizures are considered still benign, so even if it was complex, it does not mean they will always have epilepsy, does not mean they will always need EEG, MRI, LP, and sending them to neurology. But I think if you see focality, at least you could start with an EEG. And again, depending where you are, which center, where you practice, many general pediatricians can start some of the workup until they see a neurologist. Okay, now switching gears. This is a 6-month-old who presents to the general pediatrician for his 6 months vaccines, and the mother is concerned about these recurrent events. Any of the medical students or residents in the room can shout out, what do you think this is? Louder? Spasms, correct. So infantile epileptic spasm syndrome is the new name by International League Against Epilepsy, which this is known as the West syndrome. We don't use West syndrome anymore. The onset is usually, the age is less than 1 year. So again, going back to the age, you can't have spasms at the age of 5 or 6 unless you have severe epileptic encephalopathy, genetic epilepsy syndrome. The typical epileptic spasms should be within this range, so it's important to know the age. They peak between 4 and 9 months. They usually cluster, occur upon sleep transitions. Usually there's brief flexion or extension spasms like we saw in this video. Typically there's developmental regression or delay. Classic, I don't want to overwhelm anyone with EEG slides as much as I would want to, but hypsarrhythmia is important to know. They love it on all board exams, at least for the trainees in the room. And hypsarrhythmia is usually based background of EEG that is chaotic, unorganized, high voltage, multifocal epileptiform discharges. I don't want to say it's an emergency, so I used urgency. Spasms is considered an urgent presentation in child neurology. It's not like stroke, but you should try to start treatment within 1 week of identifying the spasms. And usually they used to, like at least in training, encourage general pediatricians, if you suspect spasm, refer as soon as you can. Next, we'll go through a case. So a 6-month-old, previously normal, presents with prolonged febrile hemiclonic seizure. Any hints in the case? So he's 6 months, so this is an infancy onset epilepsy. Previously normal, comes now with a prolonged febrile but hemiclonic seizure. This is textbook presentation of what people want to hear for Dravet syndrome. Key features, so these patients, again, infancy, so this is a 6-month-old. Typically, they present with a prolonged febrile seizure after their 6 months vaccines, for example. So again, something more than 15 minutes. You will not call it Dravet the first time, but usually this will become repetitive. And the hemiclonic seizure is a very important feature. So onset first year of life. Prolonged febrile seizures is very classic and often hemiclonic, so one side of the body will have repetitive clonic jerking for a prolonged period of time. The evolution then into multiple seizure types. Classic presentation, they'll come with the first febrile status, second febrile status, one non-febrile status, then they come with non-febrile seizures of multiple semiologies. It could be myoclonic seizures, then focal seizures, then atonic seizures, tonic seizures, you name it. There will always be developmental regression, but remember, they present early normal and then they regress. And one important pearl in this syndrome, as we know, it's a sodium channelopathy. So there is a malfunction of the sodium channel. So always avoid sodium channel blockers. If you live somewhere where you don't have a child neurologist and you want to start an anti-seizure medication, please don't give Lamictal or Triliptal or Tigritol or any of these. Start with something that is not a sodium channel because they will worsen the seizures. And again, in this era, we really identify these patients much earlier. They're referred very early. So many patients we've received, at least in King Faisal, less than 1 year of age. We do the genetic testing, we identify them early, and we have now, I don't want to go through this, too many details of the management for Dravet, but we have disease-specific treatment that we can start early on. Another case, 5-year-old with prior infantile spasms, and now comes with daily falls, multiple seizure types, and developmental regression. Louder? LGS. Lennox-Gastaut syndrome. Thank God nobody changed this name, so this disorder still stays the same. It's a classic end for many of the genetic epilepsies. Many patients with infantile spasm or other epilepsy syndromes will end up as Lennox-Gastaut syndrome. Again, the key features, multiple seizure types, so they can have tonic, bilateral tonic-clonic, myoclonic, you name it. However, in 2022, the International League Against Epilepsy revised the definition for many syndromes, and they actually mandated tonic seizures to be in the criteria for diagnosis. They always will have developmental delay or regression. It's typically drug resistant. I don't think we have any LGS patient who's not drug resistant. And the EEG shows the classic slow spike wave. Again, this is common on exams and they like to bring it. Some of the pearls is always remember to consider it whenever you have drug-resistant epilepsy of multiple semiologies with developmental delay, especially if you have history of infantile spasms. This is just a screenshot showing the slow spike and wave pattern in the background, 1 to 2.5 hertz. The next case, so this is an 8-year-old with nocturnal episodes of right facial tingling, drooling, inability to speak, resolve spontaneously. Healthy child, 3rd grade, comes at night to his parents with this symptom. By the time they're in the ER, it resolved. Thank you. So this is the good old benign Rolandic, which now is called other fancy names, selects, which is self-limited epilepsy with centrotemporal spikes. There's a whole paper for whoever is interested on all the new names and terminologies. I'm trying not to overwhelm everyone, but you should know the new names. So this is, usually it's a school age, so 5 to 10 years, almost always nocturnal focal seizures that involves the face and the oropharynx. Typically, they're normally developed, those children. Occasionally, the focal semiology can transition into focal clonic jerking of an arm or a leg, or even secondary generalization, the bilateral tonic-clonic, but that's less common. These actually seizures, this epilepsy is considered benign, and you don't really need to do much. Actually, in many practices, depending where you are and how liberal you are, many neurologists might not even start an anti-seizure medication. If they're not frequent and the parents are not freaking out and they're not having bilateral tonic-clonic seizures, you can get away without an anti-seizure medication. They will often at least get an EEG. You might see the spikes or even have a normal EEG, and that's okay. But if you know your semiology and age and syndrome, you probably don't need to do much, but it's a common epilepsy syndrome. There are also, although it says normal development, I have to note, they called them self-limited and removed benign because many of these disorders now are associated with at least ADHD. So just to remove the word completely benign. So there is some reports 5% of ADHD in these kids. Okay, this is the next case. So this is a 10-year-old girl with very mild concerns for inattentiveness and ADHD in class. This is another boy of a similar age. Any ideas? Louder? Yes, classic good old childhood absence epilepsy, another syndrome that did not change in terms of name. So again, this is an onset of 4 to 10 years of age. The peak is 6 to 7. They usually have frequent brief lapses in awareness, often misinterpreted as inattentiveness. They have actually 40% chance of bilateral tonic-clonic seizures, 30% will have intellectual disability, and probably around 15 to 10% will transit into juvenile myoclonic epilepsy. More than 60% have good response to treatment. This is the, again, classic generalized 3 hertz spike wave discharges. Usually patients will stare or pause or have behavioral arrest during these periods of discharges. A few words on GME. It's a common adolescent onset epilepsy. Can be a transition from absence or just starts on its own. Typically, they start with myoclonic jerks upon awakening. So the parents will come and say, she's very clumsy, he's very clumsy, drops her phone, can't hold a cup of milk in the morning without dropping it, things like this. And so it can't be misdiagnosed for a while before the bilateral tonic-clonic seizure starts, which occurs in more than 90%. Sleep deprivation and stress are classic triggers, and they unfortunately have higher rates of depression and anxiety. So overall, what are the red flags for a pediatrician and a child neurologist to consider? Developmental regression, always a bad sign. Multiple seizure types. Most syndromes, as you saw, benign ones have one semiology, and most more ominous or malignant ones have different semiologies. Infant onset. Epilepsy in infancy is not taken lightly. Of course, neonates is a whole other world, but the infant still is, it requires more attention. Increasing frequency or severity of the seizures. Any time you see poor response to treatment, or let's say you're somewhere where you can't start Keppra as a pediatrician, patient already failed it, and you're going to Oxcar, patient already failed. These are all ominous signs for either lesional epilepsy or some malignant syndrome. How do you approach them? Again, Dr. Osama went through this. Detailed history. I really don't know how neurologist functions before the era of the phones. We don't even hear the parents anymore. We just ask for the video, and you can see the full semiology, even if you don't have an EMU, probably. So still, that's very important. Assess development trajectory, very important to understand where they are in terms of development. Try to identify a seizure type and pattern if you can. If you are able to order an EEG, this will shorten the time needed until they see the neurologist. When to refer, any infant with seizures, I think, unless it's a clear febrile seizure, you should refer to a child neurologist. Suspected spasms as early as you can. Failure of first-line therapy if you're the one who started it. Progressive neurologic concerns, and at any point you have diagnostic uncertainty. Please remember, not frequent staring is not always behavioral. Morning jerks does not always mean clumsiness. Prolonged febrile seizures are not always simple or benign, and missing regression can delay diagnosis significantly. So overall, the takeaway messages here, please remember epilepsy syndromes are very pattern-based. If you know the age and semiology and guided by development, you might be able to identify the syndrome early on. Early identification in many cases, especially like spasms, can improve outcome. And when in doubt, refer them early. We will always be happy to see them. Thank you.
Thank you so much, Dr. Arawan, for keeping it on time and saving up spare time to allocate to the next speaker. The next speaker is Dr. Haneen Al-Sini. She's a consultant pediatric neurologist, epileptologist at King Fahd Armed Forces Hospital here in Jeddah. Dr. Al-Sini is a certified professional healthcare quality and a recipient of International Innovation and Research Award. She obtained a Canadian Fellowship in Epilepsy EEG from the University of Calgary. Also attended her Saudi Fellowship in Pediatric Neurology and the Saudi Board in General Pediatric. So you are very smart, Dr. Haneen, mashallah. She finished her MBBS with honor at King Abdulaziz University, and she will present a talk about paroxysmal non-epileptic event. The floor is yours, Dr. Haneen.
Thank you, Anas, for the great introduction. Good afternoon, ladies and gentlemen. So thank you for having me today. I would like first to thank the Saudi Society for Family and Community Medicine and the Dr. Osama, Dr. Ashraf, and Anas for the kind invitation. So I was asked to present today the paroxysmal epileptic events, which is a very common presentation that general practitioners and general pediatricians encounter in their daily life. So you can see them at the clinic, you can see them in the ER, and it is important to differentiate them from the epileptic events. Especially that now in the era, now we are in the era of the precision or personalized medicine. So in order to deliver the appropriate care or the personalized care, you have to identify first what's epileptic and what's not in order to start the treatment as early as possible. So first of all, our learning objectives are to recognize the most common paroxysmal and epileptic events, and that would be divided or classified by age. So I usually like to declassify them based on the pathophysiology, but some of us usually they are not a neurologist and they can't appreciate the etiology behind each of these movements. They would see them all as movement disorders or all as seizures. So for those, we usually give them a simple classification that's mainly based on age. However, if you could go with me now and bear it with me, you see them that even with after you classify them by age, you will find yourself classify them again by the etiology. And then I'll give you a very systematic, simple history taken to differentiate between each one of them. And then I'll give you the red flags, so you can have the the 5 or 6 major red flags that will interfere to the pediatric neurologist or pediatric epileptologist. And then you'll have the rule of home video. So after history or proper history, you have to have a home video, which will make your life easier. Of course, the gold diagnostic would be a video EEG to confirm the epileptogenicity of this movement. So what are PNEs, or paroxysmal and epileptic event? They are a very heterogeneous group of movements or abnormal movements. They usually have a time-limited or age-limited presentation. They have abrupt onset, so most of us mistaken them with epilepsy or with seizures. And they mimic those seizures, and usually they have no ictal correlate on the EEG. So to categorize them, I mentioned before, the age is an important criterion to classify them. So for example, in infants or neonates until the toddler age group, we usually see breath holding spells, whether it's pallid or cyanotic. And on the adult side, you could see a syncope. So both of them, they can cause anoxia to the brain, and both of them can present with a paroxysmal and epileptic event. So again, age is important. And again, tech stereotypy, dyskinesias, or different movement disorder that affect the basal ganglia can present with a seizure mimicker. And for that, taking history is important, so we need to know a pre-event, event, and post-event, the immediate recall of consciousness, if there is it suppressible or not, and if there is any associated features. Now, why it is important to differentiate epileptic from non-epileptic event? First is that almost like 43 to 50% of all the pediatric cases that are being referred to the pediatric neurologist, they tend to be referred as a seizure or query seizure, and then there will be an epileptic event, so there will be a PNE. And second of all, in the first year of life, almost 9 to 10% of those infants, they can have a paroxysmal and epileptic event. So it is considered common. And 1/4 of the pediatric epilepsy admission to the SMU or seizure monitoring unit, they are non-epileptic in origin. So for that, we are sparing the unnecessary anti-seizure medication with its all side effect, or the burden on the family, the burden and the stigmata of epilepsy that was wrongly diagnosed or labeled from the beginning. So I'll go through a very brief 5 cases of the most common presentation of PNEEs, and then I'll save the reveal of these diagnoses at the end, and then in between I'll give you the approach so you can be familiar with them. So the first neonate, he was born at term. He had no prenatal risk factors or complication at delivery, and then at 8 days of life, he presented to the general pediatrician with rhythmic bilateral myoclonic jerk during sleep. So initially, when the general pediatrician saw him, he thought of status epilepticus, so he admitted him to the ward, and then they escalated the management and they started him on phenobarbital, lidocaine, and PLP or pyridoxal phosphate, and he did not respond. His examination was non-focal, and he had normal neuroimage and normal EEG. Now, these are the movements of the child. You could see them, they're very, very brief, less than 0.5 seconds per jerk. They are very myoclonic, pretty myoclonic in semiology. And he would have them everywhere. So he would have them in the distal or proximal extremities, right, left, upper and lower, and sometimes involving the trunk. Now, the key in this baby is that those movements, they were only during sleep. So they were only during sleep. Whenever you wake up the child, they stop. The second important thing is that he had normal examination, he had no risk factors. And we'll go through the diagnosis later on. So this is after admission. They connected him to a video EEG, and you could see them having this movement, as you can see. So he jerked and then nothing on the EEG. So they were non-epileptic. The second event is a 1-year-old girl who was referred with a 3-month history of a very weird facial expression, or what we call them grimaces. So she usually get them several times per week, no diurnal variation. And the mom said that she related them with feeding. So whenever she's eating, she would have one of these movements, and she wouldn't stop eating. So she would continue just eating and then having them. She had no prenatal risk factors, exam was normal, and all the examinations were normal. So this is her, she was eating and laughing, and then my video froze. Okay. So the expression of the child would be just like if you put the eyes on her back and just slide the eyes all the way from up down. So she would just shiver. Okay, so that was the movement. The next child is a 9-year-old infant who was referred for a 2 days history of upward eye fixation, and this is very common to be called and receive this this consultation through ER, and this is a confirmed seizure with uprolling of the eyes. So those upward eye fixation, they last few seconds, 3 to 5 times a day, and the parents were very concerned that these are seizures and that the child is having epilepsy. He's only 9 months old. So this is the child. And this is the upward gazing. Here you go. And then he's back to his baseline. The fourth one is a toddler. She was referred after a seizure where she was in the nursery, and then they called the ma. Now, the event was having a very classic sequence of, first of all, she was like playing with a toy. Someone grabbed the toy or take the toy, and then she gets upset, and then she cries and cries and cries. And then she just becomes silent. Then she'll become cyanotic, blue. She will limp and lose her consciousness, and then her trunk and back will stiffen, and then after that she will get like a few jerks, and then she becomes floppy for like a few seconds, and then she's back to her baseline. And she got 2 episodes in 6 months. Every time they are preceded by crying. She had normal development, and one of her uncles, he had the same, what they called a fainting with anger. So whenever he's angry, he faints. So this is very classic, and the blue and the white one. So this is the event. So she vigorously cries, and then after that, you could see the cyanosis on the lips, and then she'll stop crying. She'll stop crying, then she'll have this behavior arrest, and then she'll become floppy. Before floppiness, she'll become very rigid, and then she will get floppy. A few seconds, and then she's back to her baseline. Here you go. The last one is an adolescent. She's a 13-year-old girl with recurrent seizures for 3 months. She gets a very prolonged generalized or bilateral seizures 2 to 3 times a week, where her whole body shakes. Side to side head movement. She thrashes her pelvis and her whole body. And then her eyes, she will just squeeze her eyes and tightly close them. And then they usually last very long, for 5 to 15 minutes. They call it every time as a status epilepticus. She presents to the ER, she received diazepam. Once she goes to the ER and they just insert the cannula, whether there's a fluid or there's diazepam, it doesn't matter, because every time it just stops, and then she's back to her baseline. No incontinence, no post-event drowsiness or sleepiness. So most of them, they happen after an argument at school or at home when she argues with her parents. She's being bullied at school, and then she had a trauma early on in her life. And then she had a completely normal neuro exam. So this is when the physician entered the room, then she started having them abruptly with no prodromal symptoms. So you could see them waxing, waning. They're not following a specific distribution. So what is the dilemma behind the paroxysmal and epileptic event? What if we diagnose them all as seizures and epilepsy, and then we discontinue the anti-seizure medication later on after the normal EEG? We have 2 concerns. The first concern, apart from the impact or the consequences of starting a medication, labeling someone with an epilepsy and having the stigmata of epilepsy, and apart from the anxiety on the parents, his quality of life, we have also the intraictal discharges on the EEG. Some of the patients, they have the abnormal event, and then they go and have a routine EEG for 30 minutes, and then the EEG is normal. And then you can't tell them that this event is non-epileptic if you don't have, if you weren't confident enough to say that these events are non-epileptic. Because the chance of capturing those events, if you don't have a seizure monitoring unit, is very low. So the golden test or the diagnostic method is to capture those events on the EEG and have that EEG showing no ictal discharges. And that's very rare, or let's say the chance of capturing is very rare. On the other hand, if you have a normal patient and he had an EEG, a spot EEG, and the EEG showed intra-ictal discharges, so that doesn't prove that that patient has seizures, or that it just increases his burden or his likelihood of developing seizures later on in his life. So correlating an event without having an ictal or a recorded simultaneous EEG on trace with the event being happening is not specific to diagnose it. And for that, we need you to be confident based on the history, and we need you to educate more the parents to have a home video. So home video is our nowadays best method of calling an event likely to be epileptic or less likely to be epileptic, and having them exposed to unnecessary side effects from anti-seizure medication or delaying a particular diagnosis, for example, and impairing their quality of life is not worth it. You can just have one video recorded at home, or you can have a proper history asking about the details of the EEG. And in a survey that they did it recently, 2 years back, they surveyed all the family physicians in 2 hospitals, and almost 45 to 50% they were uncomfortable calling an event epileptic or non-epileptic. So I think that adds to the burden of delaying management or delaying the diagnosis. So the key point is, again, history, and then home video. And the essential questions usually, as Dr. Osama mentioned in his great presentation, is having a pre-event, event, and post-event. So events that are always precipitated or always triggered by a certain trigger is less likely to be an epileptic. An event that is immediately regain consciousness after being generalized or bilateral tonic-clonic on the floor is less likely to be epileptic in nature. So the first line tool, as mentioned, is a home video. And this is the classification per age. So as I mentioned, benign myoclonus, jitriness, breath holding, sudden fear, and shuddering attacks are always seen in neonate until toddler age, while having a stereotypy, tics, syncope, daydreaming, and functional neurological disorders are more common in adolescents and older children. And those are the red flags when to refer a patient to a pediatric neurologist or a pediatric epileptologist. Having an unprovoked event, because the job of the pediatric neurologist now is to see that if he fits into one of the 3 criteria to call it an epilepsy or not. The events that are non-suppressible, non-provoked, or not triggered by a certain trigger, and having a developmental regression, as Dr. Rawan mentioned in her presentation, after a spasm or a DEE. So that all calls for an urgent neuro consultation. So this is what I mentioned, all of the 4 criteria to be reported after having an event. And then if you could feel comfortable calling them non-epileptic, then reassure the family, educate them, and have a safety plan for them. Well, if they had a positive red flag, then you can refer it to the pediatric neurologist, and the pediatric neurologist now have to do a video EEG in order to confirm the epileptogenicity. So to give the answers for the cases, the first case was a benign neonatal myoclonic sleep myoclonus, and for that we have the diagnostic clue. So the movements they were exclusively during sleep. They usually have a neuro exam, and they usually have no associated autonomic changes with the event. So what to do? Just wake him up. No need for EEG, no need for neuroimage. So these are the criteria of the benign neonatal sleep myoclonus. And then this is the second event. So we mentioned that she gets this weird facial expression. Here you go.
5 minutes.
Sorry? 5 minutes, okay. So these are the shuddering attacks, and they present in the first year of life. And in some of the cases, they found an association and not causation, association with essential tremors in the family. So sometimes they could have a positive family member with an essential tremor. That was an association based on the studies. Now, the third case was a paroxysmal tonic-up case. And the paroxysmal tonic-up case, they were found to be associated with a mild developmental delay or cognitive delay and learning difficulties in 10 to 14%. And again, it's one of an association, an observational finding that was not proved causation. And so this was the cyanotic breath holding spell. And as we all know, the cyanotic breath holding spells, the pathophysiology is the anoxia to the brain. And the difference between cyanotic and pallid is that having blue and white child, the age, so the pallid are presented usually later after in the toddlers. And the link of iron deficiency anemia is, again, an association. So usually we tend to correct an IDA if present. Now, the last one was the psychogenic non-epileptic, or the FND, or functional neurological disorder, which is common in adults and adolescents. And for this, I just need to say one word. It is a convergent disorder. It's not a malingering. So those patients, they have no control on those movements. So we usually tell them we acknowledge that these movements are involuntary. However, they will not benefit from anti-seizure medication, and they would need a behavioral management. And the last one was syncope, and syncope was the most common, again, in the childhood and adolescence. So you need to leave this room confident that history and home video are the most important method to approach patients with paroxysmal and epileptic event. You need to know that the burden of anti-seizure medication or wrong labeling patients with epilepsy while they don't have it is not always harmless. And you need to know that it is easy to differentiate between them if you dissect the history more, and if you familiarize yourself with this movement. And your age is your guide. If you're not familiar with the pathophysiology, just follow the age. The common is common. And if you're in doubt, then you just refer to the pediatric neurologist to do video EEG and then to choose the appropriate management. I would recommend Professor Rowe article that was published in 2022. He has a very nice video gallery where he keeps the most common paroxysmal and epileptic events that are common to be seen by the general practitioners. Thank you.
Thank you so much, Dr. Haneen, for breaking down PNEs. Now we will open the floor for the panel discussion and question for epilepsy. So if you have any epilepsy-related question, please. So I have a question, if you don't mind, about the recent decision to transition care of pediatrics and expand it to 18 years. I was speaking with Dr. Fawzi Battin. He's an adult neurologist, and he said he argued against this decision, though the evidence that I saw shows it's better to keep this group with pediatrics. They provide better care. But I wanted to hear your stances on it. What do you think? Are we well equipped? Will we provide good care? Will we transition kids from 16 sometimes? Is it case by case?
Thank you, Anas, for the question. Actually, me and Dr. Fawzi were planning on this project of creating a transitional epilepsy adolescent service that I was planning to lead. Actually, I was going to talk about it in the next grand round for التخصصي. I think most of these patients should be still under pediatrics, and the model internationally is at least until 16. The US and Canada is until 18, and certain states like in New York until 2021. They're actually still with pediatrics, because I don't think they're actually adults. Once they turn 14 or 15, I don't think the parents are ready for transition. There's a 50% struggle for the parents, and 50% is dealing with an adolescent who's still considered pediatrics. Even their weight, most of the genetic epilepsy patients, their weight is still pediatric weight. So I am with Now, are we ready for that? I don't know. This means you're going to expand the staffing, the clinics. You're adding a big chunk of generation of age from 14 to 18. So I don't know if the centers are ready, but I think as physicians, I think we should be able to do this, and I think it's the right model. I don't know if
Yeah, I think if I also give my personal opinion, I think also I agree with this transition into taking pediatric patients until the age of 18. There are many studies that confirms the morbidities in the kids who transition and continue with pediatrics are less in pediatric compared to adults, as we are used to take more detailed in the discussion with the family, with taking care of the medications per kg per day, etc. So I think for the patient care, it's better for pediatrics. As international model, as Dr. Rawan mentioned, yes, the North American model is until the age of 18. European model is also around the age of 17, 18 in different countries. In the MENA region and the Gulf region, at least, I believe we take ages until 12, 13, 14. This is the average age, except as I know in Qatar, they go until the age of 18. So I think most of us are willing and looking forward for this transition. On the other hand, it will carry difficulties in the hospital system settings, in the emergency admissions, especially with teenager kids in rooms that has the mothers as companions. So I think we will have some difficulties, but I think we are looking forward for this transition.
Thank you. I have a follow-up question. You practice in countries where it was 18. Did you notice more of those population from 14 to 18 in inpatient or clinic-based cases? And based on that, we can project our local cases. Would you predict that would they come more often in clinic or inpatient or equally? Or?
I think both. So I joined Dr. Osama and Dr. Rawan in their opinions. However, in everything, we have like two faces of the coin. So one is having scientifically, so most of the, even LGS, they extend until 18. So the adult epileptologist may struggle, maybe being less familiar as with the EEG finding of LGS. And that's what I found in Canada, for example. Also the genetic epilepsy, as Dr. Rawan mentioned, so they are less familiar with the genetic epilepsies, the precision management, etc. However, the literature is all like from let's say the North America or in the US. We don't have our own registry, we don't have our own database, and for that, combined with the cultural restraints, so I think that from there, the difficulty that we anticipate are coming from, and that's a call to have our own registry or database for the epilepsy, both in youth and in adults. And I think that would give us more numbers to predict if we have an issue. For more inpatient or ER visit, inpatient or outpatient, we see them more frequently in the outpatient because they are more controlled. They're more, they can control their triggers, or they can just control their sleep hygiene and these things. So we see them more in the outpatient.
I'd like to add something actually. Speaking on international models, some of the colleagues I met in the AES recently, actually even in the US, there's no model. Each center does its own way of practice, so there's not an international guide on how to do this, or nationally. So I think if we come up with something for us, like different centers with the highest population of epilepsy patients, we can come up with something that's more nationally based, because there's no model. Everybody's doing it based on resources or services they have.
Okay. So I have one last question, but just yes or no maybe. If you had the decision, would you expand it to 21?
I think I would stop at 18.
Dr. Osama, 18?
Because I don't know if I would be able to treat other disorders after 18.
Thank you. Any further questions? So before we conclude, we have one last debate question. It's quite controversial, if we can open it. This is the attendance link, by the way, if you have not scanned it. We will come back to it if needed. So there is this theory that, again, I heard Dr. Hiba once talk about it, that all the diseases, or I think the neurological condition, have genetic basis. They all go back to genetic etiologies in some sort. So there is a question, should general practitioner have direct access? It was WIS, so we changed it to EEG and MRI. But I would love to see the answer for this. Would general practitioner have direct access, should have direct access to pediatric EEG, MRI without specialist gatekeeping? So what do you think? Okay, interesting. So, each can answer. So 70% answered case by case. Okay. So just to walk you very quickly on the debate answers that we had. For the first question, should a 10-year-old with recurrent headache should a 10-year-old with recurrent headache and normal neurological exam, when will you order MRI? The vast majority answered only if red flag present. For the second question, no. Should ADHD, I think it should close. Should ADHD medication be initiated in primary care without specialist input? Most of you answered never, followed by only after specialist confirmation. For the next question, I'm just going to select a few if you don't mind to share the results. Which is the most common reason for autism diagnosis being late? We chose parental denial. And for how many red flags are enough to suspect a rare neurological disease? The majority answered more, 3 or more. And we had plenty of other questions. If you need any access to those answers or any of the content, you can reach me out later on. I would like to invite Dr. Ashraf Amir again to conclude this symposium. Dr. Ashraf.
Respected colleagues, ladies and gentlemen, as we are coming to the end of this wonderful scientific event, which is the 10 hot topics in pediatric neurology, for general practitioners, I would like to take a moment, in fact, to thank you one by one. And on behalf of the Saudi Society for Family and Community Medicine, I would like to extend our thanks to all of you for your commitment to attend and for your commitment to improve our medical knowledge and our caring for our patients. And I would like to thank all the faculties, our guest speakers who have been enriching our scientific event with a lot of updates, clinical practice, real-world evidence, and the guidelines as well. So they have been contributing very much to the success of this wonderful scientific event, and I'm sure this will be the one step in a 1,000 mile of success for the family physician and the primary care physicians to take their roles as they have been positioned to be the frontliners and to be the gatekeepers and the first contact with patients. So they have to be committed, accountable, and with this sense of responsibility and with your collaborations in pediatric and pediatric neurology, I think we will get into a harmony that will formulate the best multidisciplinary team that can manage the patient in a very holistic way. So the patient will be moving from one level primary care to secondary level without any kind of turbulence. With what we have learned today, we'll be speaking the same language of medicine for the best interest of our patients and for the best outcome that we always desire for our clinical practice. I would like to thank also our organizers, and on top of them, in fact, Dr. Anas, he's the real champion for this wonderful event, because I remember many months ago he came and he highlighted this kind of idea. So we cultivated and we took it as an important initiative to bridge the gap between the two specialty of primary care and secondary care and pediatrics. And in fact, his contribution was remarkable. And I would like, on your behalf, to extend our thanks to him, encouraging him to go further, inshallah, to have the version 2 of this scientific event, inshallah. So a special thanks for our sponsors and for Fexus Company for organizing this wonderful gathering. And I'm sure that with whatever knowledge we have learned, whatever skills we have gained today, we are going to be going with a full confidence tomorrow, inshallah, to serve our patient better. With this, ladies and gentlemen, I would like to thank you again, and I wish you a good day. May Allah accept our efforts in order to be rewarded, not only now, but for the life after. Thank you very much, and have a good day.
I'd just like to make two comments. The lunch will be downstairs. We go to the ground floor and then the basement, go further down. And if you don't mind, we want to take a group picture for everyone. So if you'd like to join us, please, we'd be pleased to have you. Please, even attendees, you are welcome to join us. Please, come. All attendees are welcome to join this group picture.